So welcome to the fourth hearing of the committee's inquiry into birth trauma. I acknowledge the Wiradjuri people, the traditional custodians on the land on which we are meeting today. I pay my respect to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name is Emma Hurst and I am Chair of the committee. I ask everyone in the room to please turn their mobile phones to silent. Owing to the nature of this inquiry, I would like to warn those in attendance and listening to this recording that evidence presented today may contain sensitive content or themes. If you feel distressed as a result of the inquiry's sensitive content and themes, please contact one of the resources available on the committee's website. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing, and I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Welcome to both of you, and thank you for giving your time to give evidence here today. Before we begin this session, I remind witnesses to avoid referring to specific names, hospitals, or medical facilities in their evidence, and to speak generally about the issues raised in the terms of reference. Could I begin by asking each witness, starting from my left, to state their name and swear either an oath or an affirmation?
My name is Carmel Biddle, and I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you.
I'm Laura Johnston. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Mrs. Biddle, did you have an opening statement that you would like to give?
I do, yeah.
Wonderful. Thank you.
My name is Carmel. I have had 8 births, 6 of those in New South Wales hospitals. I am well acquainted with what bad and good maternity care can look like. My submission focused on 3 of those births. The first, in which after birthing I was injected without my consent and treated as though I had no idea how to care for my baby. And the second, which was a twin birth, when during labour I was forced to argue with the obstetrician instead of concentrating on birthing my children and giving them the safe, natural twin birth I knew my body was capable of. My experience of birth trauma centres on the lack of empathy and understanding displayed by health professionals in the maternity field towards the women in their care. The power imbalance that occurs in that very first antenatal appointment, where they tell you how you will birth your baby. At every single appointment for my twins, I had to restate my case for a natural labour and an unassisted birth. I was laughed at, told it just didn't happen that way, told I wouldn't be able to cope with the pain, and even on the day I arrived in labour, I was asked why I hadn't turned up for my scheduled induction. An appointment I repeatedly told them that I didn't want made, but I was just ignored. The fact that I had had 5 children already made no difference to the way I was generally disrespected in 90% of my appointments. The lack of trust in the mother to make her own birthing choices about her own body and her capability to bring her own children safely into the world, I believe, is the root cause of many of the problems and incidents occurring in New South Wales maternity wards. I would like to add that I recently celebrated the birth of my 8th child, and there has been some real positive change, which proves that changing the culture around the treatment of mothers before and during their birth is definitely possible. However, there are options not available to me, which I believe it is the responsibility of the health department to make available to all mums. The most important one being to allow midwives to be on call to mothers who want a home birth. This, I believe, would be a huge step forward for New South Wales maternity care. Thank you.
Wonderful. Thank you so much. Ms. Johnston?
Yeah. So I'd just like to start by, acknowledging that there are really incredible, dedicated and supportive health professionals, midwives, allied health, etc. And I hope this inquiry leads to more support and resources for those who rely on to give the best care available for women. Going into my birth, I felt I was educated. I'd done the hospital courses online, lots of reading. I was flexible going into birth. I knew my preferences, but I also knew that I had to be very flexible. I knew the risks and the benefits. However, the system did not allow me to enact my autonomy, my knowledge, let alone my preferences. I was continually dismissed, ignored and coerced during labour by staff. I was coerced into accepting an intervention, morphine that I'd repeatedly said no to for 3 hours. Over 12 hours, the poor care and refusal of staff to listen to me, to believe me when I said I was in active labour, led to a cascade of interventions and a baby born with a low heart rate. I was also administered Syntocin, had a vacuum used, given episiotomy, and had forceps used, all without any attempt to gain any consent. The OB said to me, "I'm giving you an episiotomy now," as I was being cut. So the birth was clearly traumatic to me, but it's the way I was treated during the labour that really sticks with me. This is 2 years later. Some months after the birth, I then again felt dismissed when I was raising my concerns and complaints to management. There was some validation that my treatment had been fairly subpar and I had been dismissed and coerced, and there was an acknowledgement that there'd been a serious breach of practice in my care. However, there was also a refusal to talk to individual staff, to take seriously the lack of women-centred care I'd felt, and frankly some comments made to me by management that were just shocking. The complaint process left me feeling like the issues are systemic and so prevalent that they're now cultural. The personal cost of birth trauma to me has been significant. I've struggled with postnatal depression, which I believe my birth trauma has been a factor for, to the point that I've had a couple of months off work this year. I feel really lucky and privileged that I was able to afford to do this, and that I've financially been able to afford private psychologists and women's health physio. But I know that's a privilege not many can afford. I do believe in my case that continuity of care with a midwife would have made a huge difference to my experience. Women have no real choice in birth provider. No private midwives practice here, and despite the evidence for this model of care, the hospital having talked about it for a really long time, for years, there's no midwifery continuity of care or midwifery group practice in Wagga.
Thank you. Thank you to both of you. And I just want to thank you both for coming here today and your bravery coming forward to speak up, and your strength to be here as well. As a committee, we really appreciate it. Even though this feels like a really sort of formal and strange setup, we really appreciate your time here, and this is going to be more of a casual chat, even though it does sort of feel that, we're miles away from each other. The process now is that we're going to ask some questions. If you don't feel comfortable with any of the questions, feel free to let us know, and we'll just sort of move between ourselves asking different questions about your opening statements, but also your submissions, which we've read. I might just start with a question to you, Ms Johnson. In your opening statement, you talked about the complaints process and the problems you had there, and that it led you to feel that it was systemic. Can you just give a little bit more detail about the complaints process and the problems there, and also if you've got any advice on what you would have hoped to have seen from that complaints process?
Yeah. So I contacted the hospital, I think it was almost 8 months after the birth. I hadn't kind of received any follow-up from them in the meantime, despite it being an obviously traumatic birth, and my child ended up in special care. So I think even at that point, some offering of a debrief or support services or further things would have been important. So then I had a birth debrief. Some people at the ward, the maternity ward, and I think a debrief is a stretch because they obviously hadn't read my notes or anything. It was a conversation. And when I was followed up on the phone later, when they rang back to kind of talk through some of the things I've raised once they read my notes, I felt like in the same breath there was an admission that actually some of the things that had happened had been worse than I thought. There were some significant breaches, but it was like in the same breath it was like, but we're not going to do anything about it. There's no point talking to the individual staff. The response was, we'll resend the memo to all staff. And I think we all know what we do with those emails. The week before I'd been there kind of crying and talking about what the experience was like for me, and seeing the interventions my baby received after the birth. And I was really shocked with some of the comments that were made to me in that phone call about, if it had gone really wrong, it's fine, we can fix it. We just would have needed a little injection and, everything would have been fine. It was not a very trauma-informed attitude at all. And I felt like my main concerns about the lack of women-centred care weren't taken seriously at all. There was, like I said, there was a refusal to talk to the individual staff, which I don't understand, because that's not going to make the next woman's experience any better or make them less likely to make similar mistakes. I just felt quite dismissed.
No, thank you for that. As part of this inquiry, we're able to make recommendations to the government, a wide range of recommendations. And this is for both of you. What sort of recommendations would you really like to see in that report? I might start with you, Mrs. Biddle.
That's a really big question. There's a lot of recommendations, a lot of things that I think needs to change. Definitely the complaint process. I also put in an official complaint for after the first birth in my submission, and you just get fobbed off, really. The biggest thing that I would like to see improve here in the Riverina is there needs to be an option for home birth. We currently have no midwives here. There's a midwife who comes from Goulburn, but I personally have 4 friends in my small group of friends who have had home births, and it's not safe because the midwife can't come in time for the birth, and Wagga doesn't even know about it. There should be a midwife supplied by our local hospital for those women who want to birth at home. I don't know what that would look like practically, but there are many mothers, maybe it's because their first child they birthed in the local hospital and it was very traumatic, so now they want to birth at home. But there are many mothers who want that option, who see birth as a natural process, not a highly medicated process, and that it isn't here, and there should be that option here. That's probably the number one recommendation that I would really like to see put before the government, and something hopefully to come of it.
Thank you. Did you have anything to add?
Yeah, lots of things. I do agree with that, more access to different models of care, including home birth, to make private midwives more financially accessible through Medicare. I think it's really simple that we just need evidence-based care in our maternity system. The evidence is there for decreasing birth trauma, for having a continuity of care model, for empowering midwives to help women. I think that it's really quite simply just listening to women, following normal practices around informed consent, which I feel like, and from other people I've talked to, as soon as we're in a maternity ward, I don't know, just goes out the window. We would expect that in other areas of medicine. And bringing back to, birth being a normal process that only needs intervention when required, not going in with an assumption that an intervention will be needed. Yeah.
Thank you. Dr. Amanda Conn?
I have a question that's following on from your question, Chair, and you would probably know that we've been doing this inquiry for months now, and I've lost count of the number of stories with people that have told us that complaints and debrief and follow-up process has actually made things worse or been re-traumatising. I was really interested in your submission, Mrs. Biddle, that you talked about receiving an apology after the birth of your twins, that you used the word healing to describe that. I was wondering if you could tell us in more detail what that interaction was like to help us understand what a good follow-up process was like.
That made a huge difference. I would have put in a formal complaint after my twins' birth if I hadn't received that apology. To explain that birth a little more, I went in with the twins. They were already on the back foot because I hadn't turned up for my apparently scheduled induction appointment, which I never wanted and had never actually booked in. I also had a birth plan where I very clearly said, I'm having these babies naturally. If there are problems, I'm happy to go with whatever needs to be done. But I don't want to talk to the obstetrician unless it's necessary, unless there's a problem. Me and the midwives will birth the baby. So I went in within 15 minutes. I was already in active labour. They didn't think I was, which is always the case. So I went in, I started having my baby, called them in, and I said, first baby's been born now. And the obstetrician just stood in the doorway and was like, she needs to be on the bed, we need to be monitoring the second baby, we can't see what's going on, telling my husband to, get me off the floor. The only reason I was able to sit there and argue with him while the baby was literally crowning was because the midwife was supporting me. And I presume she got told off afterwards, but she was on the one hand saying, yes, doctor, I'll get her to. And on the other hand saying to me, carry on, you're doing great, like stay where you are. So that midwife made all the difference in that birth. And then as soon as I'd had the baby, it was like, okay, come on, we've got to get the second baby out, move. And again, I had to argue through all of that. But after the birth, about 4 hours afterwards, he came back and he explained that it was literally the first time, and he was quite an older obstetrician, I'm sure he'd seen many twins birth, but it was literally the first time he'd ever seen a mother-led twin birth, a natural twin delivery with literally no interventions. And he felt out of his depth, and he was sorry that he didn't trust me. I looked very young. And just basically just an honest apology. And it just made a huge difference for me to understand that he was out of his depth and he was unsure himself, and that's why he was trying to get me up on the bed and all that kind of thing and get all the monitors in place. It just helped me see that, he was a doctor out of his depth. And it was all new to him, having a mother telling him how she was having her twins. So, yeah, I didn't put in a formal complaint. I felt that closed the case, and, yeah, I can understand why he acted the way he did.
Can I have one more question? My question is for Ms. Johnston. You talked in your submission about the really great experience you had with physiotherapists, and I was hoping you could expand a bit more on the kind of care you received and how you had to go through accessing that. We've heard a lot of evidence from midwives and GPs and obstetricians, and not as much about physiotherapy. I'd be interested in exploring that.
Yeah, so I guess because I had some chronic pain during my pregnancy, so I was engaged through my GP with a women's health physio. I think, it was a significant cost, $100+ an appointment. So after birth, I'd already booked in with her to be seen. And I did have a post-birth injury, likely from the forceps. So, she was really fantastic. And all my friends who have seen physios, have said the same thing. But it is a matter of being able to afford it, but also to know that they're even there. No, at any stage after birth or through the pregnancy care clinic at the hospital, had anyone talked about a physio, women's health physio, at all. And I think it should be something that all women have access to. But toll on the body, and even in the best circumstances, there's likely to be an impact for women's bodies. And I believe, we don't know enough about it to know what the, not seeing a physio, what the effects might be much later on in life, and the prevalence of birth injuries and that kind of thing, because not a lot of women can access the service. There was a lot of, the physio provided me a lot of education pre and post-birth. It was incredibly helpful and helped with kind of pain and functional issues. And I saw her, sometimes weekly, fortnightly, monthly for quite a long time.
One quick follow-up. I suspect the answer is fairly obvious, but can you just clarify for the record, it wasn't possible for you to see a physio through the public system or at a lower cost?
No, it was definitely something that was ever offered or mentioned. My understanding is that people that have a 3C tear, for example, might get some physio follow-up. There's certain criteria that people might be able to access through the hospital, but the waiting lists are huge. People aren't seen in a timely manner, and it's very, very limited, at least at the hospital I birthed at.
And just to follow on from that, I was never offered any kind of physio. I had a 3-degree tear with one of the babies, and they just don't tell you that there is an option. So unless you go searching for it, and it is very financially difficult to cover, you're not going to end up getting that care that you need. Many births, I think people would need physio afterwards, but it's not available, it's too expensive.
Thank you. The Honourable Susan Carter?
Thank you both for being here. If I may, Mrs. Biddle, congratulations on the birth of your most recent child, and you've said that you've noticed some changes, and I wonder if you could sort of talk about the changes, especially as it might inform recommendations we may want to make.
Yeah, well, not so much for the obstetricians. I'm sure they've done some PD, but I didn't notice too much change there. But amongst the midwives, I noticed it was much more consistent care. All of the midwives seemed on board, but they asked me before anything if they were going to touch my stomach to feel where the baby was. They actually asked, and which is really nice. They don't have to, but they did, and they never did before. So just simple things like that. That asked, "Do you want to be weighed?" instead of go get on the weighing scales. Just little things, but it made such a difference because I felt that, unlike previously, where if I met a great midwife, it's like, "Oh, great, you're probably not going to be there for the birth." This way, I was very confident that it doesn't matter who's there. They're all listening to me. They're all respecting me. I felt, I was checked with everything. My birth, they actually went through the birth plan with me. They actually had a whole new form that they give parents now at Wagga, and for you to fill out your whole birth plan, which they didn't have before. You could bring in your own at labour, but they didn't have it before. Just little things like that, and it just made a huge difference. You came away from those antenatal appointments feeling really confident that the midwives were actually going to help you to have the birth that you wanted, rather than coming away feeling pretty down and unsure of yourself because they didn't agree with what you said or whatever. So, it was a big improvement.
And the antenatal changes, did that follow through to your experience of giving birth?
Yeah. I was actually really pleasantly surprised. When I came in for that birth, the midwife just said, "Look, there's the button, call me when you need me, but if you want to have your baby here in the room all by yourself, you can," which, was amazing because then I'd never been approached that way with birth. She told me where everything was, and she said, "We'll be outside and ready if you need us." And I did need them, and it was great. Instead of being told, do this, do that, and they're in the room, even with previous births, the fact that they're there in the room waiting for you to have the baby, it can be very stressful. You're in labour and it's progressing as it will progress at its own time, and you have two people tapping their foot. So little things like that, make all the difference.
Do you think, you're obviously a very experienced mother, do you think their attitude was because they knew that you were very experienced at giving birth, or you think it's been a change in approach to all mothers?
I think they've done some PD or something, a change. I've never noticed that anyone takes any attention when you say you've had X amount of babies before. Every birth is different. This birth was very different to my other births. It was really, really long. The others were short. So I think they kind of discount all that, really, in general. Not that I specifically noticed it this time, but I got the feeling that everyone had been spoken to and they were just changing the whole way they did things. And, So I felt very well supported this time around.
Miss Johnson, do you think if you'd been approached like that, it would have changed your antenatal and birth experience?
Yes, completely. If I'd been given any respect to kind of have some bodily autonomy, had been asked what I wanted and had those wishes respected the first time. They're really quite simple things, but yes, to feel like I was being supported, not told what to do, it would have made the world of difference.
Okay. Thank you very much.
The Honourable Sarah Mitchell.
Chair, I just wanted to follow up. Firstly, thank you both for coming and for sharing today. And it would be fairly daunting to have a bunch of politicians that you've never met asking you questions about, the birth trauma that you've been through. So thank you for being so open and honest, because it really does help us with the deliberations that we'll be having as a committee. I wanted to ask, it kind of picks up a little bit, Mrs. Biddle, on something you just said, but I think you both talked in your submissions about that continuity of care, and I know, Mrs. Biddle, you said that you had to repeat sort of to multiple midwives and doctors your birth plan throughout. I guess one question was, what are your views on how you can improve that continuity of care? We've heard in other hearings having a relationship with a couple of midwives or one doctor that you've got that implicit trust who understands what your wishes are, but obviously there can be workforce challenges with that. But I'm interested when you just said then too that when everyone was sort of following the same way of or mode of, whether it's policy or how they were with you regardless of the midwife, that gave you that consistency that you needed as opposed to it necessarily being the same person. So when we talk about continuity of care, do you think it's the individuals that matter or like the overarching kind of policy of the hospital and how they treat, birthing women?
I don't want to slam the continuity of care model. I think it can be great, but I think it can be a bit of... I think it'd be much better if there's just consistency of care across the hospital. I've had a continuity of care in other states, and what happens, which is what happened with me, if you then get to the labour and that midwife's not there. if you've changed the culture of your whole hospital and the way it deals with women, and all the midwives and the obstetricians are on board with that, it shouldn't matter if it's the same midwife or not, because they're all going to actually read your notes before the appointment, and they're all there to support women, not to tell them how to have the baby. I think, for me, I did have the continuity of care model. There was always that risk that midwife wasn't going to be there. And I thought what happened to my last baby, where all the midwives were on board, was probably better and a little bit easier for the hospital to manage as well. It can be a really good model, but I think a better model is where you just have all of your midwives properly trained to deal with women, and your obstetricians also on board. I did find with my last birth there was a bit of the midwives and everything had obviously done a little bit more PD, they'd changed their views a little bit and things. It was great, but that hadn't filtered through to the obstetricians. So I did think that was a problem. But yes, the continuity care model is still good though. I think it can be a really good option if, I don't know, retraining your entire staff is not possible.
Did you?
Can I just add that I think it's ideally women would have a choice of which model of care. For some women, continuity of care might be really important with a team of midwives, for example. There are also a lot of women who might be okay having different midwives as long as they were consistent. Like Carmel said, I think that is really important. Some women are really happy with obstetrician-led care. I think it's about women actually having a genuine choice in their model of care. And I just wanted to add too that I did have shared care with the GP, which I think is considered a continuity of care model because I had the GP consistently. I would in no way think that was a continuity of care. I saw different midwives at the hospital every time I went. No one ever discussed kind of birth plan with me. A lot of things I think probably missed. There was a rush to get through appointments and that kind of thing. And then with my GP, things that were very concerning to my GP, the hospital didn't even register on their radar. They were like, no, that doesn't matter. And the opposite happened as well. Things that my GP were like, oh, that's fine. The hospital were really, really concerned about. So they weren't even on the same page, and that just actually really added to confusion.
Yeah, especially as a first-time mum, you would be.
Yeah, and I'm trying to advocate things, but the doctors, what they saw as important didn't meet thresholds for the hospital. And then what do I advocate for? What do I so that there seemed to be a complete lack of communication between the two.
I did actually also have that model with the last baby, the shared care thing, and it totally doesn't work exactly how Laura said. So if that doesn't work. The GP, I don't think didn't know enough about birth, or maybe about the services at the hospital and the connection between the hospital and the GP clinic. They didn't send the same stuff, so that's not an answer anyway.
I feel like you're a bit passed along, we'll just make that the other person's problem.
Yeah, it didn't work.
Can I also ask Mrs. Biddle, and again, I only want you to share what you're comfortable with, but obviously from your submission, I take it that you live outside of Wagga. Because I live in the country town too, so a lot of people will go to their major regional centre for some of these services, and if there's complications and the like. So I'm certainly very well aware that happens. But you were saying that, not even having the chance to have a clinic or anything where you live, presumably you'd had to travel into Wagga for that. Yeah. How was that experience, and what would you, I guess, advocate for in terms of those women who live regionally but maybe not in that major regional centre?
I mean, I only live half an hour outside Wagga, but it's a real problem because, in my case, I have a number of small children. Yeah. I can't necessarily afford babysitting when you don't know how long you're going to be waiting at the hospital for. So every single appointment I've got to allocate about 3 hours for, to come in, to wait around, to eventually get seen, to drive back. And particularly with my last baby, it got to the point where I just couldn't make appointments. Just didn't happen. And that wasn't safe. It was only because I'd already had 8 kids that, I knew what was going on. If I was a first-time mum, it's not a safe way to go through your first pregnancy. But I just had to miss the appointments because it was too expensive to find a way to get care for the kids and come in, wait around. Being only half an hour outside Wagga, there should be something in place where a midwife comes out to Wagga to where I am once a fortnight, and and has a day where she sees all the babies in the town, all the mums in the town who are pregnant. It shouldn't be a hard thing to organise, and it would make so much difference to the mums in that town. We wouldn't have to drive in. It's very difficult, and I don't think there's an understanding of how difficult that is.
Yeah.
When you're there and you're waiting and you're looking at the clock, and for those mums who work, they're taking time off work. For those who have babysitters, every half hour is another, and there's a lot of appointments you're supposed to make. I think that would be a pretty simple thing to put in place, that, the outlying towns of Wagga, on a certain day, a midwife is there and sees the local pregnant ladies. It shouldn't be difficult, but it would make a huge difference.
Yeah, I've probably taken enough time, so I'll let them. Thank you.
The Honourable Emily Savell.
Thanks, Chair. Thanks so much to both of you for making the time to be here today and for your submissions to the inquiry. I just wanted to ask you some questions around maternity care in particular. We've heard sort of a number of different things in this inquiry about maternity care in terms of making sure the care is respectful. What actions do you think need to occur to ensure maternity care is respectful? And I know, obviously, you've given a really good example, Mrs. Riddle, about respectful maternity care that you received.
I'll let you take this
Okay. Going back to basic principles of informed consent, and that, it's just respect. Listening to women and believing them, supporting them in their decisions, talking about the risks and benefits of everything. I was told I had to have an induction. Never once did anyone mention any of the risks with having an induction. And we know there are risks and benefits. Even being really upfront and clear around what's policy and, the reasons why some things are denied, as opposed to just leaving people feeling like they're not being understood or heard. I think and being an awareness of people who have had traumatic births, being supported post-birth as well. I had whole shifts where I didn't even see a midwife at all, only on the handover points. I think there was also some really untrauma-informed things that were said to me without any understanding that I had had a traumatic birth. Some pretty bad attitudes. Pretty dismissive. I was going to say something else. It's really just basic respect and a belief in women's ability to birth, and that she does know her own body.
Yeah, and if you had, suggestions around what we could do to better ensure that occurs, or, recognising, we've also heard in other inquiries the fact that, health professionals, for the large part, don't go to work intending to do harm. So what sort of actions and measures can we take to ensure that respectful maternity care is provided?
Do you have anything to add?
I think that the birth plan, actually giving them giving mothers a form, fill out your birth plan and bring it in the next appointment, and we'll have a discussion about it. That was a new thing, and I thought it was really good. Really, it's really a cultural thing. It's changing the way they even view the mother. One thing that was quite obvious to me in a couple of the births is that the goal for the health professionals seems to be a healthy baby. Get a healthy baby out of this. It really should be a healthy and happy mum and baby. So some of the options that are given to you, for example, in my last birth, when I was talking to one of the obstetricians, straight up, it was like, so do you want a Caesar for this one? Why on earth am I having a Caesar? I'm not high risk. There's nothing wrong. And it was just sort of, well, you've had a lot of births and, you could hemorrhage. And there's all the risks going on with Caesars as well. So or with my twins, there was actually an obstetrician that I refused to see. Unfortunately, she ended up being there for the birth as well. But after seeing her 2 times, I didn't want to see her again. She spoke to me about, for the second twin, she was like, when you have twins, the second baby needs to be extracted. And what the heck's extraction? Oh, we stick our arm up inside you and pull the baby out. I was completely horrified. And she was talking about this is like having a cup of tea. And for me, talking about a woman's body that way is really bad. And as you say, she never went into work, attempting to, be offending in any way. But it was totally fine for her to suggest that to me, like it was having a cup of tea. And I was horrified. I was like, no way am I doing that. And eventually I stopped seeing her because she kept saying, well, that's just what happens with twins. The second baby needs to be extracted for the baby's safety. Whereas, it doesn't. That's just not evidence-based. It doesn't need to be extracted. So I think that it's a cultural thing that there needs to be a little bit more focus on the mother. I mean, we all want healthy babies as well, but there's 2 patients. It's just not one patient. There's 2 patients, and a healthy, happy mother after the birth should also really be a main goal.
Thanks. Sorry.
Yeah, sorry. I agree. It was if there isn't a mother that doesn't want her baby to come out safely and healthily. And there should be people there also supporting the mother to make sure she's also healthy, and safe. And it did absolutely just feel like I wasn't even in the room. There was a lack of information as to what was happening for both me and my partner. So that's really important as well. And ongoing consent. As things change in birth, consent needs to be rechecked.
Yeah, absolutely. Thank you so much to both of you. Thanks. Thanks, Chair.
You. We did start a couple of minutes late, so if it's all right with you guys if we go over a couple of minutes. Thank you. The Honourable Mark Benaziac.
Both of you spoke about problems with that shared GP midwife model. If we were to make some recommendations about improving that as a model of care, what do you think those recommendations would look like? I think both of you spoke about the lack of communication between the midwife and the GP. Would mandating some joint case conferences or joint case meetings assist in that manner, or?
To be honest, I think it's a little bit impossible to make that work.
Yeah.
Just because the GP is a GP, it's not an obstetrician. Is not quite as clued up about how maternity care works and all of that kind of thing. The midwives, on the other hand, they have all their stuff that they're doing. It seemed to me an extra lot of work when you could have it's the same amount of work just to have a shared care system just at the hospital with the same midwife. I mean, I can't think of any way that system would actually work with the shared care with the GP. I don't think it's right.
I think my only recommendation would be that the GPs that are engaging in the shared care are very aware of the hospital policies and the hospital's risk points and things so that they're actually on the same page. I think potentially it works better with GP obstetricians who also work at the hospital or have a history of working in the hospital and would be really well aware of how those systems work. I think case conferences might be ideal, but are probably a little bit unrealistic with stretched resources. I do think there probably has to be a way to make that model work better for people that live out of the main centres. That is a way for them to access care in their own town. I think one thing I did like about seeing the GP was I feel like they had a holistic approach. Wasn't just focused on the baby and the growth of the baby, but probably more broadly around the general health of the mother and mental health and that kind of thing. So I do think there are elements of the shared care model that are probably worth keeping. Yeah, but they need to be on the same page.
Wonderful. Well, thank you both so much for coming in today. We really appreciate you coming forward and sharing so openly and honestly with us, and it will really go towards helping us put this report together and make recommendations. So we really do appreciate everything and appreciate that you've come here today and your bravery for coming and sharing. something so personal as well. If we have any further questions, the Secretariat will be in contact with both of you. But thank you both again. We really appreciate it. Thank you. I now welcome our next witnesses. Thank you all for being here today and giving us your time. We're just going to go through all the formalities first, so please bear with us, and then we'll move into it all. Before we begin this session, I remind witnesses to avoid referring to specific names, hospitals or medical facilities in their evidence, and to speak generally about the issues raised in the terms of reference. Can we start by asking each witness, starting from my left, to state their name and swear either an oath or an affirmation.
My name is Francesca Mayo. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you.
Name's Belinda Alexander. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Ms. Powell?
My name is Stephanie Poll. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Do you have an opening statement? We might start again on my left. Thank you.
I speak today on behalf of myself and my husband Evan, with whom I welcomed my daughter in March 2023. What was meant to be the happiest moment of our lives ended up being a traumatic experience due to many factors. However, today I will only speak on the most impactful. This statement is not to discount the amazing support we received from the many midwives who attended us. We opted for shared care between our GP and hospital. We received amazing support from our women's health clinic, who identified our daughter's reduced growth rate at 30 weeks. Due to this, I was admitted to the hospital's complex care program, but was disappointed in the lack of continuity of care, as well as a lack of consideration for the plans developed by our GP obstetrician. At each hospital visit, I saw a different doctor. One doctor advised induction at 39 weeks. The next week, it was moved forward to 37 weeks. When I questioned this change, I was told that there was concern of potential fetal demise, despite no reported changes in my ultrasound findings. The lack of interclinic communication, collaboration, and individualisation of our plan left us worried and confused. Our induction was underpinned by more disagreement between hospital staff, which occurred right in front of us and left us feeling doubtful. We were left alone to labour as staff argued around my CTG monitor. Ultimately, we were rushed to theatre for caesarean. I raised concerns surrounding my spinal block due to my scoliosis directly to my anaesthetist and was brushed off. The resident was allowed to attempt my spinal block without my consent. The initial placement was incorrect and resulted in severe pain, but I was told that the second placement was textbook. However, when I could still feel both the ice test and the towel clamps, my concerns were dismissed twice and the surgeon was given the go-ahead. I will never forget the pain and fear I felt in the minutes that followed. I was crying out, but dismissed for a third time, told that feeling pressure was normal and offered gas. My husband was stunned, unable to advocate for me. When I was still vocalising from pain, I was given a general anaesthetic. My husband was escorted out and made to wait alone with no idea what was happening. I was well informed of the failure rates for spinal blocks. Requiring a general anaesthetic, whilst unfavourable, is not what led to our trauma. It's the fact that I was not believed that I was in pain, and this led to fear, unnecessary pain and distrust. As a veterinarian with the inability to verbally communicate with my patients, it's hard to fathom the dismissal of this direct communication. I also know that unfortunate mistakes can happen. However, the lack of accountability by the hospital has made this a difficult experience for me to process. My daughter Charlotte was born with an APGAR of 3, contributed to by the delays in surgery and the need for general anaesthesia. Waking up in recovery on my own and missing her birth were devastating, but soon after, Evan was required to leave the hospital as no private rooms were available, an unfortunate reality faced in our public hospitals. The support I received from my appointed midwife that night was a godsend, as I could not even get out of bed, let alone care for my baby on my own. Sharing my story, including with those in the profession, prompts the reply, "She's here safely and that's all that matters." Of course, we are grateful to have Charlotte here and healthy. However, this does not diminish the trauma we experienced, nor negate the necessity for improvement. A delayed initial bond with Charlotte, difficulty looking at my scar, and flashbacks to the surgery are just some of the after effects I've experienced. Evan has been equally affected, although in different ways. Initially, I thought my anaesthetic experience was a freak accident. However, I now know of a friend who went through the same thing just 3 months prior at the same hospital. It absolutely horrifies me that this is happening to other people. My motivation for speaking today is simple. I do not want anyone else to experience what I've experienced. So thank you for allowing me the opportunity to speak and for your desire to incite change.
Thank you so much for sharing that. Mrs. Alexander?
Thank you for giving me this opportunity to speak. As per my submission, I, like so many other first-time mothers, was induced. My story is not even the same. Sorry. I was not educated in detail on what exactly this would include, namely the medication used and how they would work, or the risks associated with induction. I was told about the risks to my baby if I waited for spontaneous labour. My first birth ended in an emergency caesarean after a long labour with what felt like every medical intervention and analgesia available. It took me a long time to process what exactly happened that day, and the overwhelming disappointment that I did not get the natural, empowering birth that I envisioned. After educating myself, I was very fortunate to have my second birth. Going into spontaneous labour and delivering our girl with no medical assistance or intervention and only gas at the end. My third birth, I was extremely lucky to have an obstetrician on staff who involved my husband and I in the decision-making process. I had experienced heavy bleeding during labour and was literally on the operating table ready to have another caesarean when she thankfully assessed me and told me her opinion and asked my husband and I what we would like to do. She asked whether we'd want to continue and have a Caesar or try for another VBAC. It was a completely different experience to my first birth. 4 hours later, I had another successful intervention-free birth with the help of an amazing midwife. Because of my Caesar, I was confined and restricted to what I could do during labour and the birth of my last 2 babies. This caused me a lot of frustration and disappointment, especially with the evidence and research available out there today. Due to the large number of inductions performed here in Australia, I believe women should be properly sat down and educated on what it involves and what it looks like to be induced, the risks. The cascade of interventions needs to be acknowledged so women have a better understanding of what they are consenting to when interventions are performed.
Thank you very much. Ms. Poll?
I didn't write a statement this morning. I didn't know how to start. I'm scared that my daughter's going to see this when she's older. I had my baby in the hospital. I had gone into labour and was 5 centimetres dilated. The midwife told me that there was nothing else that she could do. She couldn't find the landmarks. I didn't know what the landmarks were. So she sent me home. 5 days, I stayed at the size of a lemon, my cervix open, labouring. I was exhausted and I feared I was going to birth on the side of the road. I was then induced into the hospital. Within 7 minutes, my daughter arrived. That's not the traumatic part though. The midwife grabbed my daughter as I was bleeding heavily and walked out of the room. About an hour went past and she returned laughing that she had just given my baby to another woman. She had no tags on. I'm sorry. She thought it was funny. But this other woman couldn't be the mother because she was clearly labouring still. But my daughter was in the arms of somebody else. My daughter's older now. And I still look at her and think, I'm not sure. What if it could have been any family, it could have been given to anybody. But they just thought it was funny. And they laughed in my face. The trauma doesn't stop there though. You have to entrust your body to people. You have to entrust your children to people and nobody listens to you. All of that trauma doesn't stop. You then have to trust them when you send them to daycare. You've got to trust that these people will look after them. The hospital couldn't look after me. They couldn't look after her. You've got to trust them at school. They're not trusted. They're not safe. Injuries are happening and then it's not reported. It doesn't matter. It's all brushed off. When is somebody going to listen to us and say that enough's enough? My girl's going to grow up and she's going to have to go through birth. She has a disability just like her sister. And if they don't listen to her, there's a really strong chance that both of them will die. I don't want my children to have children. Not in Australia. I'm sorry.
That's okay. Thank you all for those statements. Ms. Poll, please don't feel that you have to share anything you don't feel comfortable with today. And as we move into the next section where we ask questions, if there's any questions that any of you don't want to answer, please just let us know that you're not comfortable with that question, and we can move on. I might begin with one question to all of you. As part of this inquiry, we will be making recommendations to the government in regards to legislative changes or funding changes. And I just wanted to understand from all of you what you think are some of the top priorities, like what would you really like to see in that report? And I might...
I have a list just from our experience. So I said that I'd like to present the following recommendations: more collaboration between practices and hospitals providing shared care services, particularly in complex cases. So in my case, I was sent in between my GP obstetrician and the hospital with a little yellow card. It mainly just had objective data, so just my temperature, my heart rate, my baby's heart rate, my fundal length. There wasn't actually any proper conveyance of important information, most importantly what the plan was for our birth. So my GP obstetrician and the hospital had two completely and conflicting ideas on what the plan for our birth should be, and essentially my husband and I were just left to decide what we thought was best, which it's good to be able to make that decision, but more guidance was definitely needed. We were left completely distraught at that time because we just felt the weight of the decision. Further education on the appropriateness of conversations occurring in the delivery room and more effort to involve parents in the decisions surrounding their baby. Inclusion of poor birth experiences, poor anaesthetic experiences and poor surgical experiences in morbidity and mortality rounds at hospitals. There was certainly no acknowledgement of what happened to us at our hospital. Like I said, it was pretty much just, oh, well, she's here. And that's just what happened to get her here, which I don't think is appropriate. Further education for maternity staff on identification of birth trauma and its effects on parents. We certainly weren't identified as a couple who had experienced a significant trauma. And routine post-birth mental health check-ins for parents followed by provision of further support if required. I think the support that we received to actually take care of Charlotte was fantastic, but I sort of, definitely felt like I was not treated as a patient, and especially not my husband. He was not even, considered. Our mental health was really something that if someone had asked us, how are you feeling after the birth, we would have really gotten a lot out of that. We sought our own mental health support, but it would have been really great. That was private and it did come at a cost. It would be really great if that was routinely offered in the public system. Yeah.
Thank you. Mrs. Alexander?
I feel like it's a hard one because it's all resource-based. You need more staff that can have the time to be with you, and education on both sides. I think first-time parents, I'm not sure the classes that are provided at the hospital are enough, and especially if there's any kind of complex issues in your pregnancy, or if you're looking like you're going to be induced. I feel like there's so many induction stories, like people aren't prepared for what it involves being induced, just education and time spent around that. I feel like all the evidence out there is all about midwifery-led care and, having that person with you that you trust the whole way through. I had, like I said, a totally different experience with my third birth. The midwife was incredible, and I only met her that day. But it makes a huge difference.
Absolutely.
My husband and I both noticed with our third, he was only born 12 weeks ago, that there was a big shift in the hospital. They asked us after the birth, how we thought it went, what if we had any questions. Like there was a totally different feel compared to our first birth. So even that was like, makes you feel like you're seen and what you feel matters. So just that shift of, I don't know what they've done up there, but some education, I guess, as well.
Wonderful. Thank you. Ms. Paul, did you have anything to add?
I just think that every patient, we don't want to be referred to as a textbook. We want you to actually read our notes. You want it to listen to us and what our body wants to do. If they had have listened to me when I said, like, I'm 5 centimetres, please don't send me home, like, please help me. My previous 2 pregnancies, I had to have help to get my waters broken to produce naturally. And as soon as my waters were broken, 7 minutes. Like, that 7 minutes could have been life or death. And it's not just her health, it's my health, it's every parent's health. I don't want anyone to have a baby that's not tagged. I think there should be at least 2 people in that room, one that has eyes on that baby and one that has eyes on the mother at all times. Do not let that child go unless it is marked with who it belongs to. No mother should ever have a fear that that's not hers.
And I'm so sorry. Just want to personally say sorry that ever happened to you. I can't imagine what that was like. The Honourable Emily Savall.
Thank you so much to you all for appearing today, for your submissions and for your opening statements. They're really valuable for this inquiry. My first question is around education that's provided to people. If we were to improve, and I know a couple of you have sort of canvassed the education or gaps in the education that's provided, if we were to improve the education that's provided to women and families, do you have suggestions around what the best mode is for us to do that? So online, fact sheets, face-to-face?
Everything's technology based. There should be an app where we can look at different options, open up pages of what a C-section could look like, what the outcomes are different, the induction, what different inductions there are. Like, you have to talk to other women. Some have had a stretch and sweep, and some have had balloon. Women that are going in for their first time haven't heard those terms until it's actually happening, and sometimes they don't even get that choice. So if you could see it all and it's all black and white with just little diagrams, everyone reads differently, everyone interprets the stuff differently. But then at the end of the day, we go to the hospital because we're entrusting the people that have got that knowledge. So, yeah, if they could just be like, look, this is an app that's generated with a lot of information. There's quick little videos of what it could look like.
Thanks. Do you have anything to add?
That's a good idea, I think.
Yeah.
I don't know, I find that really hard as well. There's so many resources out there and people can go down a lot of different avenues. It's just so hard because you don't know what's happening until you're in that situation sometimes. Yeah, I guess, yeah, that's probably the easiest way to do it. Kind of have it as an online resource or something that's easily accessible for people. Instead of, we get a lot of pamphlets and paperwork during our pregnancy clinic visits. There's always those standard ones that I think they're required to give us. But they're usually quite broad and not very specific. And then maybe once decisions are made during your pregnancy, maybe that's when they can kind of hone in on this is what you need to look into, this is what could happen. Maybe they just need those resources to tap into for women.
With the baby brains really strong around then too. So I would have preferred to watch a video about how it's going to happen, listen to it rather than have to look at the booklet, and nobody's glowing at the end of the pregnancy. It's a lie. Just tell it as it is. It's going to be scary. Lay it out there and let us dive in as deep as we want to go.
Yeah, thank you. Did you have anything to add, Mrs.
Yeah,
Miller?
I was just going to say, I think like just more giving more time to explain things in depth, particularly at the hospital importance, I think would be really valuable. I just, in comparison between the obstetrician I saw at the hospital and the anaesthetist I saw prior to the birth, a different anaesthetist, I had a really good one-on-one sort of chat with one of the anaesthetists at the hospital. They ran through all the analgesic options available to me, all the risks associated with them. That's why I felt like I went in knowing that, you know, what the percentage of failure rates for spinal blocks were and that sort of thing. I felt really well informed. But in terms of my induction, even though I felt equally informed, that information had come from me asking for that information, talking with my GP obstetrician, who I was very fortunate to have. None of that came from the doctor at the hospital who actually recommended the induction. So I think at the time that recommendation was made, there needed to be a thorough discussion as to what was going to occur.
Yeah, so I suppose, which leads to my next question around the timing of it and striking a balance between providing too much or not enough. So would it be your suggestion that that sufficient time, if possible, is allowed to give in that education when it's needed or in advance, or is there sort of... Yeah,
I think... you're right, like it is a fine line because you can leave those appointments feeling quite overwhelmed, particularly if you have gone on your own. My husband's always a lot better at asking questions than I am, but it needed to have been addressed before I was admitted into the hospital to have the induction, I suppose, yeah.
Thanks. Did any of you have anything to add before I, sorry, moved to my... Okay. My next question was to you, Mrs. Alexander. I was really pleased to hear, and also quite amazed to hear that you've given birth just some 12 weeks ago. Congratulations! I think it's extraordinary that you're here. It's as someone that has 2 young children, I struggled to make it out of the house for about the first 4 months with both of them. So well done.
Oh, thank you.
I just wonder if you could let the committee know, and I think you've got a really unique perspective, having just had a baby recently, and talk us through what it was that made things different this time around, whether there was, specific examples that were really beneficial. Yeah.
Definitely. With the induction, it was the same thing. I was admitted to the hospital. It was all started taped straight away. Nothing was really explained. It was more of okay, this is what happens next. Like, it never felt like my body took over properly. So there was always, okay, this is next. We have to do this. There was never, this is what we're going to try. Is that okay? This might happen. This is what you'll feel. The drip is horrendous. I wasn't prepared for that at all. Yeah, and it was just felt like a whirlwind, and it was the same as what the girls were saying before. It was a different attitude with the midwives as well. They were kind of sitting in the corner just watching me. Like, I didn't feel like I was supported at all, or they weren't advising. Yeah, the first birth. Yeah, sorry. So yeah, you feel like you're kind of a number taking up a bed in a regional hospital. Like, it's important for them to move you along. I get that, but it also feels like you're not doing enough. Like, what can you do? Whereas the last one, it could have easily turned into another kind of traumatic experience. I had the heavy bleeding at home, so that was pretty horrible in itself. And as soon as we got into the hospital, that midwife was the one that took me in, and the girls straight away started prepping me for a Caesar, so I knew what was happening. But they were very good about it, trying to keep me calm, and just, I don't know, it just felt like a more, not relaxed, like they were just trying to keep things calm, and they were listening to me, talking to me, like, I don't know, trying to, keep things as calm as possible. And then the obstetrician that actually gave me the chance, even though I was down in the operating theatre on the table, ready to go, she still gave me the chance to try, which, that's so thankful. I did not want another Caesar. And especially coming from the obstetricians, I feel like they're very time restrained. So for her to, I don't know, take that time and explain it all to us, and she actually asked us what would we like to do, and she explained the risks, and there were, of course, restrictions. I had to be very closely monitored, and if anything looked bad, I was straight back down for the Caesar. But I just had a totally different vibe from the staff that time with the last baby around, how they could make us feel more involved in the decision making. And the midwife was totally different. I was in the shower and she was down on her hands and knees in the shower with me. Like, she was doing everything she possibly could to make me feel more comfortable and do things, to let me labour how I wanted to labour. I don't know what they've done, but it was good.
Thanks so much. Thank you to you all. Thank you. Thanks, Chair.
And I wanted to thank Ms. Paul especially for the call to action that you've given us today. And if this committee and the Parliament and the Government and the Health Department all do our jobs, I hope that we're going to build a future where you feel safe for your daughter to also have a baby. The question that I wanted to ask, particularly Mrs. Mail, but all three of you, is about the sort of logistic or the non-medical bits of the hospital experience. And Mrs. Mail, in your submission, you talked about your husband not being able to stay with you overnight, that he was kicked out of the operating theatre and sort of left to wander. Miss Paul as well, that experience of the baby being taken out of the room where you couldn't see them or where a support person wasn't with them. So I'm sort of interested in your suggestions around those sort of practical nuts and bolts of how the hospital runs and how we can do that better.
Yeah, it's really hard because at the time we had Charlotte, it was a very busy time on the ward. So it's one of those situations where, unfortunately, I feel like it just sort of comes down to resources a little bit in terms of the rooms in particular. Like, we fully understand why Evan was not allowed to stay that night. We were in a shared room. That's understandable. But I just wonder if there had been any thought to, not that we were owed a preference, but if there is any thought to prioritising, those sorts of situations, particularly even just going through an event like that and then going into a shared room is quite confronting. I think with the dads that do have to leave the operating room, they shouldn't have to wait on their own. Like, my husband was literally just put in a room on his own with no one and just wasn't told what was going on, said he didn't even know if we were okay, and then was just taken down to meet my daughter separately, and then I was brought down later. So, yeah, I think just being a little bit more empathetic to people in that sort of situation, having someone wait with them, even just putting them in the nurse's station, like, I don't know, just somewhere where they don't have to wait on their own and they just have someone there to support them would make a big difference. Yeah.
Did if you want to add?
Having a social worker come and check on the mums, the dads, especially after what she's gone through. I had something happen like that similar with my second daughter that was born. I had nobody with me, and my partner couldn't come into the theatre room because he was sick, so he was told to go home. So, like, if he had been given an option to sit and wait somewhere in the hospital with somebody that could have checked in on him and see his mental health, he was told beforehand who's coming out, her or the baby, because we can only save one, and then told to go home. Like, it's a strong topic. But then after I'd expressed to the midwife that it's not funny to laugh about giving my baby to someone else, and I asked, like, can I talk to somebody about this? Why was there no social worker offered? It shouldn't be that once you leave, you have to go and get your own mental health support only if you can afford it. There's plenty of people looking for jobs. Even if it was a volunteer position, I would happily sit there with another mother that just wants to sit there and hold on to me while I cry. Or my partner sit there and have somebody just sit with him and talk with him, have a cup of tea or something so they're not alone. Like, make it a roster. I'm sure people would volunteer for that sort of position. I would.
Thank you. Yeah. Thanks, Chair. I just also wanted to say thank you to all three of you. Very different experiences, but all obviously very traumatic, and it's emotional. And please don't ever feel you have to apologise. And I think with what you said, Miss Poll, about your daughter, I'm sure when she's old enough, she'll be very proud of what you've been able to do today. Because unless we hear from people who have lived experiences like the three of you, we can't make suggestions around improvement. So don't underestimate the power in what you're doing today and what that will mean for many other women who have written to the committee, who have appeared before us, who have also shared similar circumstances. It is really powerful, so thank you for that. I just wanted to ask, and it's sort of picked up a bit on what Emily asked before, but around that education piece, because it is something that we've heard fairly consistently across other hearings. And the role, I guess, of birthing partners there with you. Some of the evidence we've received before has been around, particularly, I guess, when you're in that moment as a mother going through that process, having had two children, you're not always at your most sort of switched on if you've been labouring for a long time, and certainly a bit of relatability with some of your stories and my own, can I say. But I guess the role that you see of the partner in terms of helping you make that informed consent, how much they can be more involved in that process, obviously depending on an individual's circumstances. But do you think that there's a gap in terms of how we can make sure that, the dads, the birthing partners, the support people are also part of that to actually make it a little bit more seamless for the birthing mother? Are there any thoughts on that from your own experiences?
I think, like, in our experience, I think it's, especially when the father is the birthing partner, they have such a big emotional investment in the situation. Like, it's their wife, or their partner, it's their baby. I feel almost in some cases they're actually not able to advocate for the patient. That was sort of our experience. Evan was going through as much stress as I was, and he wasn't in a position to be able to say, hey, stop. She said she can feel that, stop. So, again, comes down to resources, but I feel like it's almost it needs to be someone else there, whether that's a doula or, the midwife, just someone who is removed from the situation but is there to be an advocate for the family as a whole. Yeah, it's too much to put on to the birthing partner. We didn't want any of our other family members there at the time, but I often wonder whether our experience would have been different if we had had someone else there with us who was able to look from the outside and say, hey, that's not, that's not right. Yeah.
Do either of you want to? It's up to you.
No, I agree. After the first birth, when I was educating myself on how to go with the second birth, how to approach it differently, that was a big focus on what I learned, is kind of teaching your partner how to advocate for you, because sometimes you can't. You're in a different world when you're labouring, I feel like. So we spent a lot of time educating him because he's got no medical background at all. And I even toyed with the idea of asking my sister to be there because she's a nurse and I know she's a very strong person. She would be one to stand up for me if my husband was overwhelmed with what was happening. So I agree, like having that person, even if it were like a doula or someone in the hospital, employed by the hospital, that's available in those situations, because it is... Like, I'm not sure how many times the Met Call emergency button was pressed with our first birth, but it was multiple times, and every time there's 10 or 15 people running into the room and the husband's in the corner having no idea what's going on, what's going to happen next. Just having that extra resource, because sometimes it doesn't matter how much you can educate them and get them to be advocate. They're in the situation, and their loved one, their mind is also not thinking straight in a time like that. So I like the idea of a doula or something.
I agree. I think it's really important. When I was giving birth to my daughter, if I had have been induced on the day that the hospital would have put me in, but then I was rescheduled and just made hold again, I would have had my best friend there and I would have had my partner, but because I just got pushed in the system, or you can just wait another day, or we've had something else come up and we can't do it, staffing issues, we'll just wait another day. You'll go Friday, it'll be fine. So I had no one. And my partner had just left for work. And then I birthed my daughter, and before I even knew it, I had to ask the midwife, can you grab my phone so I can take a photo of this baby on my chest because I've just birthed the baby. And then, the worst thing happened and nobody was there. If there had have been somebody else, the doctor didn't even make it in time to help with the birth because it was so quick. So it was the midwife, and she was amazing. But the other midwife that was there was the one that took her. And just having somebody in that moment that could have been like, okay, it's all right, I'm going to go off with her, or this is what they're asking you to do, and you can't think in that moment.
Thank you.
The Honourable Natasha McLaren-Jones.
Thank you very much. And again, I also want to thank you all for coming today and sharing your stories, and it's particularly understandable. We all understand how challenging that can be. One of the questions I'm interested to find out a little bit more about is the postnatal care that you were provided, and also things that could be improved and some of the recommendations that the committee could look at as well.
So we didn't have what you would normally get with postnatal care. Our daughter, because she was small for gestational age but able to be looked after by us, we went home, but she was still a patient. So we actually got extra visits from the midwife, and that, honestly, I don't know how we would have done it without that. So I think... I think we had three visits by the same midwife, which was really important, and that was just fantastic. Like, I think that should be standard. I couldn't imagine not having that, to be honest. So,
anyone else want to comment?
My son was born in a smaller hospital, and I received care every 2-3 days. A midwife was checking in on me, which was really nice. And at a larger hospital where both of my daughters were born, I didn't receive after care. I think I only seen them once, and that was just a routine check. My daughter was born with clicky hips, my middle child, so that was quite concerning, and I had to follow up with GP with that. So it would have been nice to have like a little clinic or something that you could go into. Unless you're looking for community like places, there's not really much around that can help you with that. And then to check the weight of my baby, I was going into the chemist to make sure that she was feeding correctly, because my youngest daughter was also tongue-tied, so she wasn't feeding correctly and I had to get her tongue snipped and those sort of things. It would have been nice to have the same care as the small hospital had have given for my son.
Aftercare, they were supportive. I felt like they listened to me, and I didn't have any issues, so that might have made it a bit easier. I didn't feel like I needed to ask for extra help at that time. So I felt supported.
My question is principally to Mrs. Mail, but I'm interested in other ideas as well. You clearly had a difficult decision point in terms of the 37-week, 39-week. Do you think that more information would have helped you and your husband make that decision, or do you think that is a decision that you think you needed to have a trusted, I suppose, medical companion through your birth that would make those decisions for you? Can you talk about that a bit?
Yeah, so I didn't go into depth too much in my statement, but we did have a lot of information available to us because of pretty much once we found out that she wasn't growing properly, we had weekly checks between the hospital and my GP obstetrician. They were doing extra ultrasounds, checking her blood flow measurements, everything like that. I think the issue was more that those two things didn't really come together. So my GP obstetrician, who was doing the ultrasounds, and we had amazing continuity of care with, we were seeing two practitioners, but they were working very closely together. They, I think, in hindsight, were coming from a very individualised approach. They were using what they were seeing on the ultrasound to make the recommendations. They recommended we wait until 39 weeks. The hospital, using the same findings, basically saw a small baby and pushed for induction at 37 weeks, basically expressing concerns that something was going to happen to her if we left it any longer. There wasn't any communication between those two parties, and so my husband and I were faced with, do we go early? And, we're told it's going to be safer for her. But then on the other hand, our GP obstetrician was saying, well, actually waiting longer is going to be better for her in terms of, less risk of needing special care, less risk of nutritional support, all these other long-term things. So, there was a lot of conflict there, and it just felt bad to be, in the end we were like, well, we're not going to risk her life, so that's why we decided to, go for the induction at 37 weeks. But we felt it sat bad with us that we were going against the advice from this amazing clinic that had given us such individualised care. Yeah.
Do you think there's any education or any other support that would have made that easier for you to resolve, or you think it's just a communication problem?
It's communication, yeah. I think if they had just worked together and presented us with, this is the gold standard plan, these are the other plans, we would have felt a lot more comfortable going into that situation.
Thank you. Mrs. Alexander or Ms. Pold, have you got any comments on that? Okay, thank you very much.
Well, thank you, all three of you, for coming here today and being so vulnerable and sharing your personal stories with us. I want to echo what was said by my colleague, the Honourable Sarah Mitchell, when she says that you coming forward and sharing your stories will really help us and help other women. We've had over 4,000 submissions to this inquiry, and obviously we're only going to be able to hear from a few women face to face, so thank you for putting your hand up and actually being willing to come here today and give evidence, and we really, really do appreciate it. If there are any further questions on notice, the committee will be in contact with you, and thank you all again. Thank you.
Thank you.
for coming here and appearing with us today. We really appreciate your time and your bravery for coming today. Just bear with us for a moment while we just move through the formalities. So before we begin this session, witnesses to avoid referring to specific names, hospitals or medical facilities in their evidence, and to speak generally about the issues raised in the terms of reference. Could I start by asking each witness, starting from my left, to state their name and swear either an oath or an affidavit?
My name is Hannah Ising. I solemnly swear and sincerely, truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you.
My name's Ailey Sheehan. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
My name is Courtney Signor, and I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Do we have opening statements that we want to give? I might start with you.
Yeah. My name is Hannah Ising, and my statement is called A Mother's Instinct. On this exact day, December 12th, 4 years ago, I gave birth to my first daughter. The events that unfolded in the week after left me utterly traumatised and completely disappointed, and give me the right to have a voice that speaks for myself and many other women in saying that when we become mothers, we're given one of the most powerful tools known in the biological world, instinct, and it's not being heard. I had a high-risk pregnancy due to an underlying heart condition. I was induced at 38 weeks, and my birth plan was delivered to me without my consideration by someone I'd never met. I was told to have an epidural, which failed. It resulted in the complete loss of sensation in one leg and being completely numb from my belly button down. My baby girl was born healthy, and the attending obstetrician sutured my 4 first-degree tears, the result of a fast delivery and complete inability to feel my baby crowning. She removed small fragments of my placenta from my uterus and displayed them on the tip of her finger for the whole room to see. All the expected checks on baby were performed with no troubles, and we were constantly encouraged to go home before day 3 so you can get the home care nurse visit. Within 48 hours of the birth, I began feeling unwell with readings of high blood pressure. I told every staff member that entered the room throughout the day that I wasn't feeling well and that something wasn't right. It was all shrugged off as, you just gave birth, are you drinking enough water? It's lack of sleep, it's from breastfeeding. Despite the continued high blood pressure, I was discharged on day 3. At the home care midwife visit on day 4, I explained I was still extremely nauseous, had no appetite and felt horrible. Despite my cardiac history, she had nothing to do with me at that visit and just checked the baby. By day 5, I felt horribly ill and knew something was terribly wrong. On discharge from the maternity unit, you're provided a sheet of paper that says if you have any symptoms of headache, swelling or nausea, to call the midwifery unit. So I did and was encouraged to attend the unit for a check. I attended with a high blood pressure reading of 170/90. Was told I could have a stroke or a seizure at any moment, that I might have to be separated from my newborn. I was readmitted overnight and I was discharged again the next day, informing everyone present in my care that I still didn't feel right. By day 7 on December 19, we again called the midwifery unit, was told to re-attend the birthing suite again for an exam since I was showing no signs of improvement. I was monitored during the day. They reported my blood pressure was again too high but appeared stable. They were organising my discharge that same day, and during the assessment I had a midwife see me who shut us away from everyone else and said not to listen to the obstetric staff but to go immediately to the emergency to be seen. That midwife saved my life. I was seen promptly in the emergency with a high blood pressure of 160/100 and immediately admitted as I was presenting with a well-known but rare postpartum complication called postpartum preeclampsia. I was admitted to the critical care unit for 4 days before finally being discharged, now well, for the 3rd and last time on December 23rd. While I should have been at home for the first 2 weeks of my life as a mother, loving on our beautiful miracle baby, I was in and out of hospital and disregarded by staff who consistently brushed off my medical concerns to the point where I was discharged and readmitted 3 times in a week. There was never any follow-up. I never heard or saw from anyone in the obstetric and maternity ward ever again. I had to make my own 6-week follow-ups for myself and present my experience myself. I had to seek my own mental health review and trust my own instinct that how I process these events may not be normal. From this experience, I was counselled for a year and medicated for postnatal anxiety and PTSD.
I experienced severe panic about the whereabouts and safety of my daughter constantly and experienced nightmares that reiterated back that I was told that I may be separated from my daughter for the first 2 years of her life. I experienced my first ever panic attack related to postpartum high blood pressure 2 days after the birth of my second daughter 3 years later because of the hell that I went through after my first birth. It said you should always trust a mother's instinct, but what about when it's about the mother herself? From these experiences, my recommendations for reducing the incidence of birth trauma are as follows. Scheduling postpartum health and mental wellbeing checkups occurring simultaneously to a newborn 6-week growth check. A reminder service to be sent out in the simple same format that you receive a reminder about the baby's first vaccination. Genuine continuity of care, especially in rural areas where many women opt for GP shared care for affordability and ease of access, but as soon as the babies are born, the process stops. Why aren't there scheduled follow-ups for the mother in this extremely vulnerable time? Hospital follow-up. Hospitals have the resources and social worker staff to support the rollout of a simple follow-up for women whose birth resulted in adverse events. This could open up a conversation that a mother suffering deeply in the trenches of postpartum mental health issues desperately needs help with. And then simply home care nursing visits to include taking vitals. What if I had trusted the opinions of healthcare staff overseeing me? What if I hadn't trusted my instincts and repeatedly returned to hospital? This simple inclusion could save someone's life. Thank you.
Thank you. Mrs. Sheehan?
Firstly, I appreciate the time and the platform you've created for myself and others in a similar situation to have a voice. To summarise my experience, I have 2 main points to make that myself and my husband feel are the major contributors to the New South Wales health system failing me. Communication that includes consultation timeframes and informed discussions. My post-surgery consultation was delayed by 14 hours. The impact of this was uncertainty between midwives, their management and timelines. As a result, for nearly 2 days, I remained covered in remnants of placental expulsion and meconium and I wasn't even offered a sponge bath. When discharge from the first hospital was directed, I was made I feel I had no choice but to leave the major hospital because of a bed shortage. I was given the option to drive myself or use patient transport. Being in no condition to drive, I opted for patient transport, which arrived 5 hours after the allocated time with no explanation. As a result, I arrived at the next hospital late at night. The impact of this was utter exhaustion, isolation, and immense pain. This brings me to my next point. Continuity of information between midwives and between hospitals. Among other things, I was on a complicated treatment regimen. Before leaving the major hospital, I had to ask the midwife to develop a spreadsheet so I was up to speed. When I arrived at the second hospital, it came to light that both hospitals had not communicated the details around my case clearly. As a result, I did not have access to medications required. I had to prompt the nurse to dispense my next treatment. After much resistance, she retrieved my allocated dose of antibiotics and locked the rest away. I was refused analgesia throughout the night and no discussion of any ongoing pain management or any other aspect of my treatment plan. The impact, utter exhaustion, isolation, and immense pain. The lack of care had a flow-on effect that resulted in being readmitted to hospital 5 hours after discharge. The lack of care is a direct result of staffing shortages, bed shortages. The lack of continuity could be curbed by allocating midwives to patients, much like doctors to patients. Over 4 days, I never saw the same midwife and everyone had changed my routine. I'm positive this will ensure more engaged employees and deliver better patient care. As a first-time mother with a 4th-degree perineal tear, I don't think it is appropriate to transport any patient to another hospital, especially late at night. If the regional hospitals are unable to support a woman about to give birth, then staff the major hospitals accordingly. Supply an appropriate number of beds to support the continually growing population. The physical and emotional stress had a direct impact on my milk production and hormone production, and I feel this could have been avoided had I had the support, guidance, and informed discussions required for a successful discharge and recovery. Thank you.
Thank you. Mrs. Signal?
After 3 years of trying to fall pregnant, fertility treatment, and surgery, I finally fell pregnant with our miracle. But due to my BMI and a health condition that I had under control, I was automatically classed as high risk, and I was unable to do shared care. This meant that I had to travel 3 hours return for every appointment to the closest high-risk clinic. Instead of seeing my GP, who knew my history and who I trusted, I instead saw a different doctor every time and continually got told I was healthy and did not need to be classed as high risk. For this and many other reasons, I would strongly recommend that shared care should be allowed for all women, especially those who live rurally, and that your BMI should not be a factor in the way a pregnant woman is treated or classed. It is an inaccurate and outdated method that many midwives and doctors do not agree with. The way we were spoken to and treated from the time we arrived at the hospital was horrendous, to say the least. I understand that for the medical personnel it may be the end of their shift, but it is important to remember you were dealing with people's lives. You were there for them on some of the happiest, scariest, and sometimes saddest days of their lives, and this is not something to be taken lightly. But sadly, we were just treated as another one to be pushed through as quickly as possible. I was put on the Syntocin and drip to speed up my labour, despite feeling confident in how I was progressing and coping well with contractions. This led to me requiring an epidural, and my baby's heart rate started dropping only after the drip was started, and I ended up having an emergency C-section. I strongly believe and recommend that timeframes should not be put on women labouring. The Syntocin and drip should not be unnecessarily used to speed up labour. As was clearly explained in the antenatal classes we attended, medical intervention leads to a cascade of medical intervention, which was something I experienced. In the World Health Organisation's recommendations for augmentation of labour in 2014, it states, augmentation with synthetic oxytocin may result in uterine hyperstimulation with adverse effects such as fetal asphyxia and uterine rupture, and thus increase the risk of a cascade of interventions during labour and delivery. Besides, such unwarranted clinical intervention deprives women of their autonomy and dignity during labour and may negatively impact their childbirth experience. Once our son was born, he was resuscitated as he had the cord wrapped around his neck. However, this is not information I was told. I only found out by reading a chart and then his blue book. He then spent 6 hours on oxygen in the special care nursery. At 24 hours old, he contracted a severe MRSA infection, which is a staph infection that is difficult to treat because of resistance to antibiotics. Once again, information I was not told by anyone at the hospital. It was a doctor in our hometown that explained the seriousness of this infection he had. This infection led to my newborn baby needing a cannula and high-dose antibiotics, which has contributed to his ongoing medical issues. I was also not checked by a doctor before getting discharged and was sent home with a severe infection in my uterine lining that required 2 courses of strong antibiotics to treat. When I got discharged, I was just told they really needed my bed. I would highly recommend that there are single rooms only in maternity wards so that women can have the support and get the rest they so desperately need after giving birth. I was placed in a double room, which meant I was unable to rest and I could not have my husband stay with me. I would also recommend that parents should be given a rundown of the birth and any complications that resulted once the mother is stable and recovered enough to comprehend what is being discussed. Enough resources need to be allocated so that women and their babies can all be given the time to be fully checked and reviewed by doctors, and simple hygiene practices should be reviewed regularly. Sadly, due to the way we were all treated, we have spent the first year of our son's life dealing with issues and conditions that would have been avoided had we been given the time and attention we deserved. And the joy from the experience of becoming first-time parents has forever been robbed from my husband and I. It is my hope that by telling our story, and by hopefully the implementation of some of these recommendations that will be made, that women will be able to feel safe and in control when giving birth, and that the mothers, babies and families are treated with the respect that we all deserve.
Thank you. Thank you again, all of you, for coming in today. We're now moving into some questions, so we're just going to sort of move between us and throw different questions. If there's any questions you don't feel comfortable to answer, please say so. Or if there's any additional information that you think we're not asking, you've all sort of touched a little bit on experiences of giving birth in rural and regional areas in your opening statements. And I just wanted to hear a little bit more around the unique sort of situation of giving birth in a regional or rural area, but also, what we really need to focus on specifically for women so that they actually feel safe giving birth in a rural area. I'm happy for if any of you have any to throw to any of you.
At the time I lived at Gundagai, so that's a little over an hour from here, and there is a hospital in Gundagai. It's really small. I went in at 36 weeks with a kidney infection, and they, for lack of a better term, they freaked out and they said, "I can't deal with you here. You need to go to Wagga." And I was in Wagga for, only a few hours. They gave me some fluids, sent me home. So that was fine. There was no complication after that. It was a little bit scary because anything could happen in that hour, me driving. If for some reason, if I'm by myself, I'm heavily pregnant, and just the distance alone, and then not being able to support me while I was there. During the time that I was post-birth and had to change hospitals because of the bed shortage, that was a little bit obviously more traumatic because I absolutely did not feel like I could travel at all. That was horrible, let alone being offered to drive myself with a birthing injury. So that absolutely needs to be addressed. Yes, the regional hospitals are really great. They're a lot smaller. You do feel like you get a little bit more personalised care when you are there. Not when I arrived, but the midwife that I had the second one on the next day was a bit better. But I think if these hospitals are going to be in these little satellite hospitals around, they just need to be better equipped with mostly staffing, I think, and obviously I don't expect to have a midwife at everyone, but definitely the people that know what they're doing. I know Wagga in particular has to service such a large area, all these little towns around, because you can't give birth at these little towns. If they're going to have to deal with that extra pressure or population pressure, then they need to be able to service it accordingly, in my experience.
Yeah, jump in.
Because I was interested, Michelle, when you mentioned that before. So after being in Wagga for a few days, you went to Tumut.
Yeah.
But you lived in Gundagai.
But I lived in Gundagai,
right?
yeah.
And that was just because there was no.
Gundagai could not handle. There's no way. I don't know their bed situation. It's attached to a nursing hospital.
Yeah.
They've got an emergency area, and then the nursing hospital's on the other side. There's no beds or anything.
Okay,
like
but
that.
in Tumut there is a maternity ward with midwives, but you can't actually give birth in Tumut. Is that?
Don't
you
know.
can, depending. I could ask the health district this afternoon.
I'm from Tumut. You can give birth in Tumut, and it is a beautiful maternity ward, and I would have loved to have given birth there.
Okay. Is that a risk factor thing? Is that the?
But because I was automatically classed as high risk, I wasn't allowed.
Yeah. Sorry. Thank you. Sorry to take.
I might clarify because I came to Wagga. I worked in Wagga at the time, so the triangle was just too hard.
Yeah. But you didn't choose to go to Tumut.
Pardon?
You didn't choose. You wouldn't have chosen to go to Tumut. It's just
because obviously because I worked in Wagga, I had all my appointments in Wagga because obviously I could just duck off to work to have doctors and things like that here. So going to Tumut wasn't an option for me.
Okay. But then you had to after you'd given birth because they needed to put you somewhere.
They needed the bed, yeah. So they transferred me to Tumut. And that back then, I don't know what year you gave birth in, but it was the old hospital then, so it was a little bit different to what it is now. Yeah. And it was so dated and massively uncomfortable. It's built in the 20s or something.
Yeah. Okay.
So it was that in itself was a little bit different again. The facilities just weren't up to scratch.
Okay. Sorry to hijack your question.
No, that's right. Sorry, Mrs. Ising, did you have anything to add?
I think an important feature that most women in rural areas will have that's quite consistent is the GP shared care program. Obstetricians come with their own out-of-pocket expenses that people in rural areas aren't always equipped to be able to supply. And with that, the lack of communication between these departments is embarrassing. I personally was juggled between 3 departments as a high-risk patient with the maternity shared care program. Went through my GP, went on to the cardiac ward, went to maternity ward, and I had a different person every time. No one had a cohesive plan. Every person generated their own opinion. So I think that a level of communication, again, in the previous discussion, there was the mention you just walk in with a yellow card that's got your baby's heart rate and your weight on it. It's useless. There needs to be a more detailed sharing of information that's personalised so that you can get a personalised approach.
Thank you. Mrs. Signor, did you have anything to add around the experiences of regional and rural women?
I do think, my only experience, I've only had one child. So my only experience was that I was not allowed the shared care. So I haven't experienced what that is like. I would have loved shared care because my GP knows me in and out. She knows my entire history. She's a family doctor. I had to take excessive amounts of time off work because it was a 3-hour round trip. When you're heavily pregnant, you need half the day, easy. It's hard to go back to work in the afternoon. But had I just been, and then when I was at those appointments, I got told I was healthy, you don't need to be classed as high risk. They were never longer than 10 minutes. I just didn't see the point in that at all, and why I couldn't have that shared care, why I couldn't go to the local hospital for checks, why I had to travel that distance.
Yeah. Thank you. I wanted to ask as well, one of the strong themes that has come up in this inquiry is about being informed and having that information. And I guess there's some discussion about whether that is best sort of received from the healthcare professionals directly, or whether it's information on an app or more flyers. But we're also hearing that a lot of people are overwhelmed by the information on flyers and the reading that's available. Is it something that you would, do you feel it would be better to come from a healthcare professional and to have more time with somebody that would talk you through potential situations that could happen during birth, or is it something that should be, on a written piece of information to take home?
I think both.
Yeah, I think both. A simple way to involve it would just be with, in a regional hospital, you have the opportunity of 2 birth classes, that a very small personalised group, you spend a whole day with a couple of midwives, and at no point do they discuss anything adverse. They have a really dated video that shows the first few days with a newborn. They don't talk about any kind of things to look out for with baby's health and the mother's health as well. So I think that would be a really easy implementation, is update that video with something that gives more information to parents.
You don't always have questions like on the spot when you're in the room. I always get them when I'm in the shower. Do you know what I mean? Like I think, and maybe post-birth, I YouTubed myself to death to point to the point where I was crying, like sitting on the bed trying to breastfeed because it was so hard, and it drove me nuts. So having it in your hand is just as important as having it in your consultation, I think.
I think both. You need to be able to have that conversation with somebody who has the time. When you're being rushed through, this is your weight, this is your baby's heart rate, this is your baby's growth, cool, you're good, we'll see you in a couple of weeks. It's not very conducive to any conversation around what might happen coming, and it's not really until the last few weeks that they start talking about what will happen at the birth or what could happen at the birth. But it is important to be able to go home and read these things and look at it, but to have somebody who has the time just to have that conversation with you where you don't feel in a rush and you don't have to have these questions pre-prepared because you're not going to. Baby brain is, as it was mentioned, a very real thing. Yeah, just having a doctor that has the time, even half an hour, would have been great.
Thank you. Honourable Susan Carter?
Thank you all for being here. Very, very grateful that you're here sharing with us. A question to all of you, perhaps starting with Mrs. Ising and then Mrs. Sheehan and then Mrs. Signor. What difference would it have made if you would have had somebody to talk with or follow up or support you after the birth? And what would that have looked like? And would that have been helpful, or were you just too busy that it wouldn't have been helpful?
Would have been completely helpful. I think it may shorten the length of time it takes to make your own intervention. It reduces the severity of it as things progress, they get worse. So if it was addressed sooner, mental health issues specifically, then I think the opportunity for intervention would be much easier to initiate. Some kind of support system that extends beyond, are you okay? Every mother is going to go, yeah, I'm good. It needs to address certain questions, and in the thick of it, nobody knows what to look for. Are you having nightmares? Are you worried about your baby's health? Things like that. It needs to be a broader conversation, and that's a more personalised approach as well.
Thank you.
I think so. Once I left the hospital, this is the benefit of living in a country town, my child maternity nurse lived directly across the road. And I didn't know that until the end, but it was lovely. But I had one visit from her, and that was a few weeks afterwards. Yeah, it was really great. But I think in the immediate future, like after leaving hospital, absolutely. Whether it's daily or a couple of times a week, maybe 3 times a week or something, absolutely, that care. And especially if the number of beds is a problem in your hospital and they're trying to kick you out early, like you're a number, then you need to increase the amount of care that goes on after hospital. I feel like I was kind of a person that I was not sick enough to be in hospital, but too sick to go home. That transition period really needs a really strong support system, and in-home care when you are in your own environment and you do get to relax and do things a little bit better, but you still have somebody at the other end of the phone or somebody that you know is going to be there at 9 o'clock the next morning. That would be amazing.
I don't think there was enough after-birth support. I was the same. I got the one home visit after going home 6 days after giving birth because my son was in the special care nursery fighting off this horrible infection. Sent home on high-dose antibiotics, told follow up at home. Follow up with your GP. Go into the hospital at home if you're worried. And there were looking back now and knowing the things I know now, so many things that were going on with him that if I had have had the support and someone who cared enough to follow through, I wouldn't have had to fight for as long as I had to fight for just to get him the help he needed. It would have made the world of difference to us.
If I could ask a follow-up question, and if any of you have any views, because I think what I'm hearing is that there are post-birth mental health needs, there are post-birth caring for your child needs, and post-birth mother needs. Can the one person address all of those, or is it best if the one person is trying to address all of those because that provides continuity of care and you don't have lots of different faces that you're talking to?
I think the continuity of care is key. I think the one person, and they need to be skilled in multiple areas, obviously. I think, that one person regularly in home. And I mean, you can always cancel the service if you want, if you find you're flying high, great. But I think I especially as well had problems with my baby afterwards. My husband was a great support person, but he also was like, oh my God, I'm here for you, you're here for him. Do you know what I mean? It's I think somebody needs to be there for us as a family.
Yeah. Thank you.
First of all, I think happy birthday to your daughter today. I hope you get to go and do something more fun after, it involves celebration, I'm sure. But my question was actually more to you, Mrs. Sheen. You attached a copy in your submission of the letter that you wrote to the Health District and just outlining, obviously, the experience that you had. Could you tell us a little bit more? I think you said you did get a call from someone at some point to talk through that, and obviously not naming names, and then you haven't really heard much in terms of follow-up. I guess, what were you expecting out of that process? What would that have looked like for you in an ideal situation in terms of that feedback post you making that? I'll say complaint, but, raising the issue.
It was a complaint. I do remember having that conversation with her. It was some time afterwards. And she was lovely. She made the time to go through every single paragraph with me, and so I did feel like I was heard then. And she did ask me the same question. She's like, what do you want out of this? And I said, well, I don't really understand how the system works as far as what should happen after this and what other people have done, but I just want to make it clear that not everyone has the same background as I do in the medical background. I know it's not human, but it's still within the same realm. And if I wasn't educated enough to ask the questions that I did, then somebody in the same situation without that background would have had a much worse experience than what I would have done. And I feel for those people, and I just don't want that to be replicated in other families. And my husband, he still is, right? He hates speaking about everything that happened to us because he thinks it's, in his mind, he was just as traumatised as what I was, if you know what I mean. So I think there needs to be the support for those people as well.
Yeah.
What should happen here? I mean, this ultimately it's happening now, and I think that's not that I expected a parliamentary inquiry from my submission, but I think that it's important that we see that you guys hear us, and that those recommendations are going to be put forward and that something's done about it.
Yeah.
And we want the system changed ultimately.
Yeah. Thank you.
To support us.
Yeah.
Thank you, Dr. Amanda Conn?
I had a question for Mrs. Signor, but please jump in if you had thoughts as well. I was particularly interested in your written submission when you talked about having to pay to board when your baby was in the special care nursery. And I know you were sitting in the audience earlier today when we were talking about other people's experiences with family members not being able to stay in the hospital with them, etc. This seems like something relatively straightforward to fix. Can you tell us about that experience, having had to board, but also what what a perfect version would have looked like?
Yep. So my son was born at 8:21 at night. It was 9:30 by the time I'd gotten out of surgery. Both my husband and my mum were there with us. I got told I was going into a shared room, so my mum had to, late at night, drive home to tube it. And I was on the phone in the special care nursery, laying in a bed next to my baby, on the phone, trying to get my husband accommodation. After just having this major surgery. And so I was in the dub room, I got him, it was horrible having to say goodbye to him. And then I think it was maybe day 3, day 4, I just got told, we really need your bed, but if you're willing to, you can pay to board. So we need your bed, we need you to leave, but you can pay to stay here, which just made absolutely no sense to me. And then later that day they said, actually, no, you can't, we need you to go. So the option was Ronald McDonald House. We were fortunate enough that then they found the family room in the special care nursery was free, and they said both you and your husband can stay there and you can stay close to your baby, which was fabulous. But I didn't really understand why that hadn't been an option from the beginning, considering we were not only first-time parents, but from out of town, had no family living in town. It was sort of just added insult to injury.
Just trying to understand in terms of recommendations from us what a better model would have looked like. Is it being able to stay in the hospital, in the room? Do we need to be looking at care or accommodation that's adjacent to hospitals that have patients come in from out of town?
I think what would have helped most is just a single room. Like, they don't need to be huge. You need a bed and a chair for your partner, somewhere for your baby. Shared bathroom, fine. But just a single room. Because, giving birth is so difficult. And then going into a room with another woman who's just given birth and her newborn baby and your newborn baby, you can't rest. And I had a midwife tell me, you need to rest, you need to sleep. But how? It just doesn't work. And yeah, the rooms don't have to be huge and full of all this amazing stuff. Like cut the rooms in half. But if I had have had my husband stay with me, the rest I would have gotten would have been amazing.
I agree. I was in a similar situation. I gave birth at 6 and I didn't get out of surgery till midnight, and my husband then had to drive back to Gundagai, and like over an hour away. So even just for that first night, it would be, even just for the support to hold the baby sometimes when you can't, or you need just another half an hour sleep, to have the husband in the room, it is a monumental relief. We ended up back in on the paediatric ward a few days later, and they had even just a fold out, like it was a giant couch, but it was like a sofa, just for a single sofa. Even something as basic as that, even though, it doesn't take up much room. It doesn't have to be a whole bed for Dad. It's just something that he can just roll out until the next day and then go home and, get himself freshened up and come back. But because, I went into labour at 5 a.m, and so we had been up for nearly 24 hours. And driving that distance in the night along a major highway was just dangerous for him. And having that little couch would have been amazing.
The Honourable Emily Spall.
Chair, thanks so much to you all for being here today and for the evidence you've given to the inquiry. It's really, really welcome. Thank you. I just wanted to ask if any of you had, obviously we make recommendations after the conclusion of all our hearings. We write a report that has some recommendations. In terms of maternity care that you may or may not have had that was positive, if you could, and that may not be the case, but I'm just particularly interested in if you've had an experience which was really positive, what you think it was that made it so, and how we can encourage more or create more of that, if that makes sense.
With the birth of my second daughter, I opted for obstetric and private midwife care, and keeping the same face present throughout the whole thing, and then even on the ward, same faces, makes the world of a difference. Resource-wise, it's obviously not always possible, but I think some level of familiarity in any domain possible makes a huge difference.
I agree. Like I said earlier in my statement, I think it's the midwives should be allocated in a similar fashion to the doctors, having that continuity of care, because the amount of times there was a shift change and, oh, you're doing it wrong, you shouldn't have this, you should be doing it that way. Like every single time I got a new, and it just increases the anxiety and things like that. So I understand, yes, there are shift changes and you are in there for multiple days sometimes. If there's a couple of people that are allocated to this wing of the ward or something like that, absolutely, yeah.
Something very similar, whereas every new midwife that came on came with new suggestions telling me that the way the last midwife had told me to do it was actually wrong. you're trying to breastfeed. No, you don't do it this way. You do it this way. I was very fortunate. I did have one amazing midwife. And I think it was her calmness and understanding and the fact she just really listened to me. And everything I said to her, she just listened. And she was ready to help how I wanted and how I needed, not how she thought it needed to happen. It was the same. Another midwife came and they wanted to take my baby for a couple of hours so that I could rest because I wasn't. The way it was said to me the first time just broke me into tears, and I said, "You're not taking my baby. You're not going anywhere near him." And then another midwife came and she knelt beside my bed and she listened to me cry. And she said, "I will bring him back the minute he wakes up for his next feed, and I won't leave his side." And it was just her understanding and her care. So those two midwives, I will never forget them, because that's all I needed. I needed that bit of care and that love and that understanding. That was all I needed.
Yeah, thank you. Thanks. Thanks, Chair.
Are there any further questions? Well, thank you, all three of you, for coming forward today. As we've said to other witnesses this morning, we're so grateful for everybody that has come forward and your bravery in sharing such personal stories. And it's so important for us to actually hear individual experiences as a committee to help us to make those recommendations. And you're really paving the way for women going forward. So thank you so much. If we have any further questions on notice, the committee will be in contact with you about those. But thank you again so much for your time today.
Thank you.
Thank you. The committee will now break until 11:30. I now welcome our next witnesses. Before we go into this session, I remind witnesses to avoid referring to specific names, hospitals or medical facilities in their evidence, and to speak generally about the issues raised in their terms of reference. I'd like to ask, first of all, for each witness, starting from my left, to state their name and swear either an oath or an affirmation.
My name is Dr. Trudy Beck. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much.
I'm Dr. Carl Henman. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Wonderful. Do either of you have an opening statement that you'd like to give? Yes, Dr. Beck?
So I would like to acknowledge the traditional owners of the land on which we meet, the Wiradjuri people. As a mum of 3, I have frequently reflected with gratitude on the safe 3 empowering births I have experienced, the second and third of which were under a GP obstetric model of care at our local public hospital. I am a GP obstetrician and provide intrapartum care at our local hospital and community-based care in a private multidisciplinary women's health clinic. Our clinic's mission is to empower women and their families with knowledge as they embark on their journey into parenthood, and then to provide a safe, supportive space for them to find their new normal. It has been a privilege to sit with over 400 women in the last 2 years since we opened, as they have told their stories of pregnancy and childbirth. We offer coordinated medical, pelvic physiotherapy, perinatal psychology, dietetic, exercise, parenting and peer support services. This inquiry elicits many complex thoughts and emotions from me as I walk the line of knowing the empowerment of birth, understanding the principles of women-centred care, but also witnessing the inherent uncertainties and dangers of the physiological process of birth. Australia has one of the lowest perinatal mortality rates in the world, particularly intrapartum, and my professional experience of this is that as a clinician we are trained to hold safety as one of our guiding principles. In holding safety as a core value, I witness the conflict that arises between what a woman and her birthing partner ideally would like for their birth and the interventions that often occur. While I think effective communication, known provider, and informed consent go a great way towards protecting from trauma and optimising outcomes, I still have difficulty reconciling the challenges that exist in simultaneously providing a nurturing maternal experience alongside exceptional maternal and neonatal outcomes. I am mindful of and humbled by the opportunity women and their partners give us to be involved in the journey to become a family. Pregnancy and birth are biologically and physiologically normal processes, and we should take immense joy in the privilege we are afforded in witnessing matrescence unfold. I believe this inquiry comes at a time when both families and those working in the birth space are seeking a trigger for cultural evolution in this realm, and I welcome the recommendations of this process and hope that they can constructively point the way forward.
Dr. Henman?
Yeah, thanks. Good morning, Chair and committee members. Thank you for inviting me to speak. First of all, I'd just like to share something. During my time working as an intrapartum clinician at my local regional hospital, the overwhelming majority of clinical interactions that I witnessed between midwives and patients were conducted with expertise, compassion and the utmost professionalism. Furthermore, I imagine that the majority of those patients would not only agree with my sentiments, but would state that they did not suffer any long-term physical or mental birth trauma. Most patient birth experiences are good ones, conducted in a healthcare system that by international standards we're very lucky to have available. But that doesn't mean it can't be improved. That being said, I recognise we're here today, why we're here today, and that there have been a number of women who have suffered significant birth trauma and prolonged negative sequelae secondary to their experiences within our health services. Hence, happy to offer my insights and in order to reduce the frequency of these events in the future. Prior to writing my own submission and attending today, I read through many other submissions and transcripts from recent hearings. It is of no surprise to me that the vast majority of these submissions detailed a lack of one or more of the following: continuity of care, individualised care, a trusted lead care provider. There is anecdotal and literature-based evidence that continuous individualised care is associated with improved outcomes and a better patient experience. Unfortunately, our healthcare system, particularly the public one, is decreasingly likely to facilitate a model in which this care type can be offered. Much is made of multidisciplinary teams, medical subspecialisations and clinic-based care. While these entities have their value and each health professional within them no doubt has best intentions, they are, by their very well-intentioned nature, causing ever-increasing fragmentation of care. This leads to less continuity in time to establish a therapeutic relationship and a lead care provider, exactly the opposite to what these women and their partners need at one of the most vulnerable times in their lives. Hence, my number one recommendation is that significant time and resources are put into promoting, encouraging and facilitating longitudinal models of care under a trusted lead care provider that crosses the threshold of the hospital foyer. There is more than one model that can satisfy these criteria, but on the background of many of my own wonderful, profound clinical experiences, the barriers to the obstetric GP model in regional centres should be dismantled and this care type reinvigorated and prioritised.
Wonderful. Thank you both, and thank you both for being here. I also want to recognise that the local member, Dr. Joe McGurr, is here with us as well today, and he's been here with us this morning, and we appreciate him coming here today and spending his time with us. At this point, we're going to just ask questions to either of you about your submission or your opening statements. I might start with Dr. Amanda Conn.
Questions for Dr. Henman. In your opening statement, you mentioned barriers to GP obstetricians being able to provide intrapartum care in hospitals. We've heard, this morning and from every other hearing so far about the value of continuity of care, and particularly from other witnesses this morning about the preference of some women to have GP shared care. Can you expand what some of those current barriers are?
I think, unfortunately, it seems to be a reflection of probably the way the obstetric profession is going overall, that there are less and less GP obstetrician opportunities, particularly in regional and metropolitan centres. GP obstetricians are utilised well in more rural locations, but without them they would have no one. This inquiry is not about my situation in particular, nor should it be, but the barriers to me continuing that care, they're still somewhat confusing to me as well. I don't really understand why, after 7 or 8 years of providing the service myself, that it was abruptly, essentially terminated without clinical reasoning or explanation. You will probably find that some explanation would be on the guise of a narrowing scope of practice guideline that seems to be reflective of a very risk-averse culture, and medical administrations probably on the background of an ever-increasing concern over medico-legal implications, less inclined to want to have people involved in care who they don't view as the specialists in the field. And so we are reducing a scope of practice at the expense of continuity. And I think the vast majority of the time we just can't avoid all risk. And when we try to do so, we raise the possibility of other problems. The first one, and the one being repeated in this inquiry, not only today it seems, but in the other hearings that I've read transcripts of, is that there is a disruption in continuity and an almost inability to establish a relationship through all of the pregnancy, which includes the intrapartum environment. I suppose I wish I had all the answers. Some of those answers should probably come from other people.
I'm happy for Dr. Beck to jump in as well. Do you have any constructive suggestions for us in terms of how we can improve continuity that's provided in public hospitals?
I guess I am in a unique position in that I do straddle the private and public systems in our region because I have a ongoing contract to provide intrapartum services at the hospital, not in a GP VMO role, but I'm happy in the contract that I'm in that it fits the demographics of the patients that I look after. So I guess I walk a careful line there because what my main priority is to maintain excellent working relationships with the midwives who I really value and trust their friendship and their collegiality. And I think that there's a very healthy relationship in our particular hospital between both medical and midwifery staff. I guess from the outsider perspective, referring into a hospital, I would think that my experience would be similar to all other GPs in that we have been used to being the point of reference for our patients, and over long periods of time we've developed, I hope, trustful and caring, mutually kind of beneficial relationships with our patients, and we don't ever claim to know everything. Like, I think GPs are very good at recognising the limitations of their scope of practice and then seeking specialist advice beyond that. But it's an unusual experience, I would imagine, for some of our patients when we do the referral to hospital. It's almost as though the patient then belongs to the hospital, and I don't know that that's the hospital's intention. However, my experience of it from both the inside and the outside is that regardless of the pre-existing relationship I may have with a patient, the hospital then takes ownership, and in doing so, I believe probably then they do that knowing that they also take on the large load of the medico-legal responsibility of it. But I think that then comes back to the idea that my belief from working in the system has been that safety and the kind of minimisation wherever possible of risk has potentially come at expense of true collaborative care. And I can't criticise that fully because I understand that it's well-intentioned. However, I believe that the patient experience of that may look like fragmentation. And I guess that all of us who are here with the hope of decreasing that fragmentation, because we all have seen and witnessed the unavoidable nature of some women's experience of trauma in childbirth. But if we can increase the lines of communication and the shared responsibility for patients, then perhaps we can provide a more seamless pathway to patients feeling held when they are returned to their previous primary caregiver, which in both Dr. Hemman's and my instance would be general practice.
Last one. You touched on sort of the communication issues between GPs and the hospital, and I'm particularly interested in the experiences of your colleagues who are not GP obstetricians, but who are GPs that a patient has chosen for shared care, and what are the practical opportunities to influence that communication? How can we improve that so that we improve patient experience of GP shared care?
Well, I think I'm coming back later in the day to be in alignment with the PHN who coordinate our local shared care pathway. I certainly think that shared care in this region is highly valued, and I think that there's a good program that exists in place to do that. I guess that there's limited opportunity for an external provider to comfortably access advice through the hospital system if they're not familiar with the system. Like, the pathway that Dr. Hemman and I provide means that at any one time we will probably be providing some form of shared care arrangement for maybe up to 150 or 200 women on our books at any one time between us. So I feel really comfortable with picking up the phone and knowing who the appropriate person at the hospital is to call for advice. And I frequently do that because, as we've all mentioned, like, continuity and consistency of care is really key. But I guess if you don't have as much to do with the hospital system, sometimes in the pressures that exist within normal general practice consultations, the idea of picking up the phone, calling switch, maybe getting through to someone that's in a theatre case, and then you'll get called back later, and by that time the patient, you can see that the difficulty that can exist just trying to logistically coordinate something. So I guess it's I know the hospitals have New South Wales hospitals have done a lot of work on the idea of GP liaison officers and things like that, and I certainly think that it would be again, allocation of resources? How do you have a touch point of a senior clinician, whether it be doctor or midwife in the hospital, that is easily accessible to outside providers?
Honourable Sarah Mitchell.
Thank you. We've got a little bit of time. Thank you both for your submissions and for being here today. I wanted to ask, it's probably directed to you, Dr. Henman, because it's come out of your submission, but I'm also happy, Dr. Beck, for you to provide some insights as well. I thought it was interesting when you talked about particularly like women being aware of reasonable expectations of what may happen. And I think one of the things we've found through this process is that it can be very subjective. You know, women can have very similar birthing experiences but have very different emotional and physical responses to them. I guess in terms of, we've had some women sort of talk about wanting to have better information in a prenatal sense, really understanding what the risks and complications are, whether it's through induction or assisted delivery. From your experience, do you think there are ways that that process could be improved? I mean, obviously you've got that unique one-on-one relationship with that GP sort of model of care, which as someone who lives in a regional area, I had that too and it was wonderful, but I know that's not everyone's experience. Do you think across the system or across the board there are things that we could recommend in that space to help women feel as if they're more empowered and informed before they actually reach the point of being in labour? What would you suggest?
Yeah, do you mean specifically when they're attending public clinics or separate to...
Either or, anything that you think would be useful for us.
Well, I suppose the first thing is just to hark back to the previous point that if we encourage, to use that example, GP obstetric models of care, well then I think those models of care are more likely to be associated with that trusted care provider who is more likely, and I'll say more able in the sense of they have the GP obstetrician gets to make the decision about how long they spend with them. I sort of have a bit of a caveat there, I suppose, because in private land we're not really more able, somewhat in a financial sense, because it's quite difficult in the private setting to spend a long time each time, but that would be ideal. If a woman isn't choosing or unable to choose that particular model and they were seeing the public antenatal clinic, for instance, if we're going to model it on how I do it now, or more specifically did it when I knew I was going to be the intrapartum carer, and at about the 36-week visit, and it doesn't exactly matter when it is, but I made sure I spent time talking through what I thought were the more likely, possible scenarios that might occur in labour, and getting an idea at that time what that woman's preference, if you like, was as to how she would like her birth managed, and sometimes that's, I want you to do everything that you think is safe right up to the point of being maybe not safe in order to get a vaginal delivery, and other times it's like, if you think it's going badly early, then I'm happy to have a Caesar really early. And that allows you then the opportunity in the labour ward to make those decisions, knowing that you've essentially already had somewhat of a consent process occur. The consent that we are able to do in an intrapartum setting is, I would say, makes a mockery of consent, really. So, doing it in that setting, I don't think. I mean, you've got to do it, because if you don't do it at all, you're in trouble. But I don't really think it amounts to sort of a good time to give them information. So I think probably establishing maybe a system or a particular appointment time where those types of things could be discussed would be a reasonable way to go about that, and or in the education surrounding those people who are likely to be involved, even if it is in a intermittent sense through that woman's journey, to remember to talk about those things. I mean, it's as simple sometimes as just asking, what is your expectation? If she's got a complete placenta previa and breech and she says, my expectation is to have a vaginal delivery, well, I hope that I will be able to reset her expectation. She said 3 previous normal vaginal deliveries and her expectation is a vaginal delivery, I'll say that's extremely likely. But without that education, we shouldn't necessarily assume that the woman sitting in front of us will know why something is unreasonable. If we go into something with an unreasonable expectation and then we don't get what we want, as humans, we're just inherently disappointed. But we didn't need to be that way if we were otherwise well educated about what might be in front of us. As I say, it harks back to having a trusted care provider who you feel as though you can ask those questions of, or knows you in such a way that will raise those topics appropriately.
Did you want to add anything, Dr. Beck?
I think I agree with Dr. Hemman that the process of consent is inherently difficult during birth, particularly in the pressure points where you're having to make decisions in a rapid way. The approach that I take, which everyone's slightly different in how they would manage these kinds of expectations in the different models of care we use. So I use the resources that are already out there and I think that are getting quite widely acknowledged. I like to have other women tell their birth stories. So Australian Birth Stories is something that I know, a podcast that the hospital recommends in clinic and I do as well, because I think that I can explain to you as many ways as you are willing to listen about the things that could happen to you in childbirth. But hearing it from another woman's perspective is, we know that storytelling is a huge part of birth. And so I am grateful to the resource that she puts out there in that podcast, and I encourage all of my women to listen to that. The hospital does a really good job with their it's done over 2 days usually, their antenatal education days, in terms of just going through, what the possibilities are and what to expect. And then I guess when I think about what things I would like to see come out of this is the idea that birth planning is actually really important. And even in the women that I see who are generally often quite well educated, have good health literacy, I say to them the same as Dr. Hemman would in their third trimester, like, have you started to think about the birth? And what I guess as healthcare providers I think we should be railing against is the idea of paternalistic style medicine, where they say, oh, well, I'll just do whatever seems right because I just want a healthy baby. I actually don't think that facilitates change. And so I go to them, encourage them over in between visits to think about 3 key questions that they would like to put to their care providers in birth. And that would be, the first thing is, what would you like us to know? What we would like you to know about us. So it could be, I had a previous traumatic birth and I'm looking to try and heal some of those old wounds, or I have had a abuse history and I would like trauma sensitive care, or I really know that my personal feeling is I don't like pain and I'd like an epidural. Like the things that get to know rapport with your care provider quickly, so that you don't have to spend a lot of time explaining those things, things that they'd really like for their birth and things that they'd like to avoid if possible. Because once they've thought about those things, I say discuss it with your birthing partner, and then their points for advocacy for your partner to say. And the other thing is, which I think we could do a better job of, because we don't necessarily learn it in midwifery school or in medicine, is patient-centered communication. So I think when it comes to consent, a lot of the time we, even ourselves, might not fully understand what that process entails, and it shouldn't be driven by our inherent biases about what we think is safe or what we think the right thing is, that we almost always have time to say to a woman and her partner, hey, this is what the situation is at the moment. We're at this kind of fork in the roads. These are the options I can suggest to you. These are the pros and cons of each. What do you think? And I think that when it's come down to it, like we've talked a lot about continuity of care, but you can have, in my opinion, from what an external perspective would be, what looks like a traumatic birth. And I think if they've gone into it with an idea of what to expect, that they've had clear communication and a feeling of autonomy in decision making, that they can come out the other side and be like, that was a wild ride, but don't carry with them that sympathetic overdrive ongoing of that was trauma. Their brain is able to process it in a different way. And so I know that the committee's goal is not to eliminate birth trauma altogether, because I think that we all accept that that's potentially not the goal of this. But I guess that's my anecdotal observation, is that women can experience and undergo things that we can be vicariously traumatized by witnessing it. But if they feel safe and held and understand rationale behind things, that their brain processes it in a different way.
And I think just picking up on the consent piece, I think that's a really interesting point, because obviously it's something that has come up in other hearings that we've had and from other witnesses about sort of making those decisions in the moment. And, you know, when you're having your baby, you're maybe not at your most eloquent in terms of processing things. And so I think, you know, that idea of having conversation and really kind of knowing, I guess, beforehand what the ideal, and I think those 3 questions are excellent examples of what we could do, because I think the committee is quite conscious too of not adding extra barrier. I mean, we don't want to have less people being able to have babies, particularly in regional areas, and, you know, we want to support our workforce, and I think that's really important that we don't get too tied up in kind of medico-legal issues that makes people not want to come and work out here. And so I just wonder what the piece is around that earlier support, which I think you've covered quite articulately, because I wouldn't want us to recommend anything that would actually make it harder for people like you and your colleagues to do your jobs, particularly in the region. So is there anything we should avoid?
Well, I think that we should acknowledge that New South Wales Health does make an attempt to facilitate this in terms of women will receive a birth preferences sheet at one of their 3rd trimester visits. However, my feeling around that and the women's experience of that is most of them look at it, they look at the form and they're like, I don't know what to do with this. Not because they're not informed, but because how can you explain to someone the need for some of those interventions antenatally? So I think that I would like to be a midwife in lots of ways. I just think I'm not patient enough because midwifery is an art. Midwifery is not a tick box process. Like the process of being with a woman in birth it's something you feel. Like you can't learn it from a textbook. Like it's something that you do because you have a deep desire to sit with women. And midwives don't need, my friendship with the midwives that I work with means they don't need a tick box. What they want to know is, how can I develop a quick rapport with this patient so that I can take them through this really, really challenging day of their life. And so I guess that we're always on a slippery slope in medicine of more medicalisation, I suppose. And one of the things that we try to do in our private practice is say, this is a choose your own adventure. Like, this is an amazing and exciting and like incredible part of your life. And how can we make this about your story more than about your statistics?
Yeah.
I think if we talk about consent in the sense of consenting to someone looking after you, when we have a trusted care provider, I would say that the babies that I delivered, those women throughout the journey said, I consent to you, Carl, looking after me. I consent essentially to you making the decisions, right? In an environment where the person making the big decision and doing the big thing at the pinnacle moment is someone who they've never met, I think they look back on it and say, I didn't consent to you making that decision. And I think that's a difference, right? The woman feels like, okay, I said yes, but I didn't consent to you making that decision for me. Whereas you've got a trusted long-term relationship with someone. Most women, the vast majority of women get it. They get it. It's dangerous. It can be really difficult, and they want to be safely looked after. But they want to be safely looked after, on the background of feeling that the right decisions were made, individualised to them. And so I think that's where it falls over a little bit, when the first time they see the person who's going to put the forceps on or make that decision is when they're at the end of the bed. The person putting the forceps on, I'm sure, 99.999% of the time has got the 100% the best intentions. But it's about more than best intentions. As Trudy says, it's about that sense of what's the right thing to do for that woman in that moment, and how will she look back on that. It wasn't uncommon for me when the situation was not acute, in the sense you could give the labour a bit longer to go on, for instance. So you can have another, for example, half an hour or an hour, and we'll see how things go. Now, not uncommonly looking back, thinking to myself, I know how this is going to go. I know how this baby's coming out. But I also know that, and this was not uncommon, that I've walked up from my rooms that morning, having seen a woman at 6-week or 2-week check, having done a similar process in her labour, and she'd said to me, I'm glad you gave me that extra hour.
Yeah,
I really feel I had that opportunity, and then once the Caesar was done, I felt that I was given the best opportunity to have, or at least to try to achieve.
Yep.
Right. So I think that's another advantage of a longitudinal trusted care provider, is that they're there 2, 6, 8 weeks later as well. And there's nothing like having been there at the bedside to know what really happened. So I recognise that we're not going to magically develop thousands of GP obstetricians that are going to work in regional and rural areas. They could work in metropolitan areas too. I just want to make that point. We seem to have pushed GP obstetricians.
We'll take them in the regions.
But it's not going to happen metropolitanly, I know that. So, I think the public system is going to have to try and take some of these recommendations on in order to address these issues, because and try and fit these types of suggestions into their model of care.
Yeah.
Because we're not, people like Trudy and I aren't just going to magically appear and fix this problem. So, I think that's probably a secondary recommendation to the continuity of care type argument.
Yeah. Thank you. I'll let someone else.
I actually just want to do a follow-up to Dr. Henman around that whole idea of I haven't consented to you making those decisions, or sort of more like this idea of broad consent when you know the healthcare provider. Some of the women that we've spoken to have talked about feeling trauma from individual sort of informed consent, like, suddenly they're getting a vaginal exam that nobody sort of said, do you mind if I do this? Or, this is what we're going to do now, or this is the safest thing to do now. Are you okay with that? Do you think that there's also sort of a need for that kind of informed consent sort of throughout the process, so that the woman still feels like they're part of that entire process?
Oh, definitely. And I think, those examples, and I read similar things in some of the submissions, that when I was reading those submissions, I thought to myself, I can see that from the doctor's perspective, that this looked like it was turning south quickly, and they wanted to know, for example, what position the head was in, because they thought, quickly we're going to have to deliver this baby and I need to know the position for that. And the consent in that particular setting is, like I said before, probably not ideal consent. But I think if you had explained to that lady prior to labour that this might have to occur for these reasons, she's a bit less likely to say, well, I felt assaulted because I didn't really feel as though I gave that unknown face specific consent to do an internal examination. You're never going to address every last, trauma that comes from that, because the situations are emotionally charged. But I think if you've prepared her emotionally for what might happen in labour, it will go some ways to addressing that.
Yeah, absolutely. Yeah. In your submission, you said that we currently have a self-sabotaging healthcare system that's ill-equipped to provide education. Is that related to that sort of true continuity of care, or is it something sort of more? Can you help me unpack that?
Yeah, I think that mostly that's what I'm referring to there. That it's there's so many sort of people involved, I suppose, that it's very difficult for a woman to feel as though their care is being individualised. Multidisciplinary care is great, but multidisciplinary care is not continuity of care. It's interesting, actually. I read a transcript from a hearing, I don't know, a few hearings ago, I don't know when it was, and the witness was asked, tell us about continuity and what your view is of general practice, continuity in GP obstetric care. And the next couple of paragraphs in the transcript were talking about the multidisciplinary approach and all the different people that the women see in that particular person's clinic. So I just, that's not continuity. That's not allowing that woman to sort of feel as though she's been well educated by one person who might be able to bring together all the different views that were put to that woman by all those different multidisciplinary teams. Because again, we're very well intentioned, every person in that group, but the more you fragment care, I think the more generalised care ends up being. And I alluded to before that the public system does have significant constraints on it in relation to time. It's not uncommon for me to hear that a woman might wait 2 or 3 hours to be seen in a clinic. Now, that's not because people are sitting around having coffee, it's because they're really busy. We've heard it a number of times even this morning and plenty of times in previous submissions and transcripts about resource allocation. But I think that essentially contributes to this self-sabotaging, if you'd like, because they feel as though the system has to see a certain number of people in a particular clinic at a certain time. There's only so many hours in the day. So I think part of this is resource allocation, and part of it's sort of not necessarily putting someone in those places who is charged with the responsibility of being the lead care provider for a group of women. And that's fleetingly occurred to me that could be a way in which you could address some of this. Is it's unreasonable to expect the O&G director of any particular unit to be charged with the responsibility of all the patients in that unit. That's just not how it's going to work. But you could have a situation where a certain number of women were only ever, where the final decisions, antenatal decisions, were made by a particular, for example, non-GP specialist obstetrician, if we're talking about public systems.
Thank you. Yeah. Dr. Beck, in an interview earlier this year, you talked about informed consent and that it isn't mainstream enough. Can you talk a little bit further about this and how we make informed consent mainstream through the system?
So I guess my experience of this, and again, this is only my personal experience, is that I can't ever actually recollect at any point in time in my obstetric training having specific training around informed consent. And I'm aware, just through keeping up with my CPD, that RANZCOG is doing lots of work around incorporating more modules in their mandatory training around communication, and I expect that this will, the outcome of committees like this will be to add informed consent as a specific topic. But I think sometimes we feel time pressure where it's actually really important to spend the extra 30 seconds on something, and it might feel like you don't have time at the time, but I guess one of my interests has just been how I can focus on more women-centred care. And I certainly think personally, to practice in alignment with my values, it would be that each patient I spend time with believes that I am truly present with them. And in doing so, what information would I want conferred to me when I was to make an important decision? And so we talk about consent, but consent's not just doing a New South Wales Health checklist of we're taking you for a Caesar and you could have these complications. And consent is, like what I just said before, this is the fork in the road that we're at. This is, in my clinical opinion, what I think is going on. My training would lead me to believe that these are the options that are available to you. The pros and cons of each of these options are these. What do you think? And so it's even just being, I'm lucky enough to spend a lot of time with really great junior doctors, and even just picking them up on the nuances of their language around how they say, I'm going to do this, is that okay? That's not informed consent. Informed consent is, because of this reason, I think that I would like to offer you a cannula. How do you feel about that? So I think it's like, it's not what you say, it's how you say it. And I think, again, when you look back at how far all medical practices, but particularly obstetrics, have come in the last few decades, it's incremental change that has to occur, and picking each other up on when we say something to our patients, recognising that there is an inherent knowledge and therefore power differential, and how do we be humble clinicians who, it's not shared decision making. I think that that's a thing of the past. It's actual true informed consent.
Absolutely. The Honourable Emily Savell.
Thanks to you both for appearing today and for all your ongoing work in advocating for women in the regions in particular. I just wanted to build on these questions around consent. In our first hearing, we heard some evidence from the chair of the Human Rights in Childbirth, who described consent that should occur for a woman that was required to have an unplanned forceps birth. And in this evidence, they stated that someone should ideally come into the room 10 to 15 minutes beforehand and say, this is something that we need to do, or the alternative is that we would recommend you have a C-section. Then you step out, give her 5 minutes to think about it and talk with her partner or her support person. Is this an appropriate and realistic way for gaining consent, would you say?
So I guess that this is the kind of scenario that I am expecting to be dealt with at any time on any given shift, as would be anyone working in a birth suite. Yes, that is the ideal situation. And even when it comes to things like caesarean sections, there's very few emergency situations where there isn't time for the patient, their birth support people and the midwife looking after them to reflect on it. And I guess my personal feeling is that when I go into a room, it's not a resounding yes, let's go, then I will always say to them, I'm going to give you some time to think about this. I guess in other circumstances, it conflicts with RANZCOG's own guidelines around this in the instance of things like fetal bradycardia, where the timeline is such that there just isn't the opportunity for that style of informed consent, where they say that within 6 minutes you should be making a plan to expedite delivery, and within kind of that 12-ish minute mark the baby should be born. So you can see the timeframes for that are much tighter, particularly when often we're not alerted to a deteriorating situation until it's already at the point of potential crisis. I would say in that circumstance it's inherently difficult to have a true process of informed consent, but going back to what Dr. Henman said, I think if in an ideal situation, which in a lot of cases it is an ideal situation, that the patient already has formed rapport with the midwife has already kind of alerted them to the increasing urgency of the situation, that often by the time you arrive, that process of verbal consent is almost on the way to theatre, unfortunately. But again, as I kind of alluded to earlier, grapple with walking the line of safety profiles and what our kind of standard of care in Australia to the trauma that obviously occurs if you have a poor maternal or neonatal outcome.
Yeah, I think that's eloquently described by Trudy. I think there are times where it would be sometimes a rare number of times really where that is entirely inappropriate, because a 5-minute, bradycardia of 50 beats a minute could have lifelong sequelae. Yeah. Most of the time you probably have got opportunity for that. I used to have something called my postcode speech, which was, okay, this is not really acutely a major issue right now, but it's not going that well, and it's 10 p.m. and we're in a regional hospital, and I know theatre's going home, and I know how long theatre takes to get back. And in this postcode, it's going to take me an hour to get knife to skin when none of them are here. But for example, Royal Randwick, the theatre is where you are, and the woman is where I am, and it takes 1 minute. And that makes a difference. So it's not only about reasonable expectation of clinical outcomes and opportunity, it's about reasonable expectation of where that occurs and what resources you have available to you. And so recommendations that come from this committee, I think, will probably need to keep that in mind, that some will be very appropriate for certain settings and some will be less appropriate for other settings.
Yeah, thank you. That's really, very good for us to keep in mind in terms of forming the recommendations as well. If it's clinically identified or indicated that the intervention is required in a time, and you've given us, some examples around that sort of time-critical nature of some of these interventions, is it appropriate to then offer a woman the choice of an emergency caesarean or a forceps birth, or would it be, is that an appropriate thing to do? Or?
I think that when you were asking before about antenatal education around birth choices and what might occur, I feel like I'm not a senior clinician, but I wouldn't probably not class myself as a junior clinician anymore either. And I feel like every year my knowledge bank builds around patterns of behaviour and what you might be expecting to occur, or if you see or feel something that doesn't feel right, that your antenna goes up and you're like, through previous experience, this doesn't seem right. And I think that that's where the whole idea of trusted providers is so helpful, is because I can't hand on heart say that I can consent antenatally any of my patients to what could or couldn't happen in labour. And sometimes it's not even until the last minute that you know yourself what's going to be the most desirable outcome. So, like, again, just like midwifery, I think obstetric medicine is an art, and there's a degree of human error in there which we will continuously self-reflect on, and in the middle of the night, sometimes you're still up thinking about things where the patient might have had a great experience, but it's actually you're taking that uncertainty, or did I do this right or did I not do that right? And I think the day that I stop questioning that would probably be the day that I would stop doing this, because we're all always looking for best outcomes for the woman physically and emotionally, and that decision often is made under extreme time pressure.
Yeah, thanks. Dr. Hammond, did you have anything to add to that? No?
Not to that. Can I go back to...
Go for it. Yep.
You asked about my comment about self-sabotaging health system in relation to individualised care. Mm-hmm. Another thing that occurred to me sitting here is about sort of what seems to me often be a rigid adherence to certain guidelines. Someone, I can't remember who, but a senior person once said to me, guidelines are for the advice of wise men and the adherence of fools. Right? So, but if we have a system which won't allow us to work on the edges of guidelines in order to individualise care, we then work in a self-sabotaging system, because those women won't be happy that they weren't given the opportunity to have something on the edge of a guideline. Now, we've been talking about intrapartum stuff here. I'm not even really thinking about that. I'm thinking something as simple as giving someone an iron infusion that doesn't necessarily fit with the Red Cross guidelines about when that should be done, because of that individual or that woman's particular circumstance, and when she might be able to have it, how long away from town she is. Is she already here, but she's going to have it at a certain gestational week, she'll have to travel to Hay and back, for example. So I think we need to pay some attention to the fact that guidelines are reasonable, they're there for safety, but stepping outside the guidelines on the background of individualised care doesn't equate to it being unsafe necessarily.
Thanks. Just a final question from me to you, Dr. Hemman. Earlier in today's hearing, you mentioned that multidisciplinary care is not continuity of care. I'm just keen to understand what evidence you have to support that idea, or where that's come from.
I would say that it's evidence of my own experience, I suppose, rather than being able to quote a particular author to you. Just because lots of people are involved in one woman's care doesn't mean that she will feel as though she's been managed in a continual sense throughout. I suppose I'm saying that a continuous care model allows that woman's journey to be individualised to her, whereas many multidisciplinary inputs will find it more difficult to individualise care, because they all have their own idea about what that particular woman is best for that particular woman. But when that woman has a central care provider who she can discuss those ideas with, we're more likely to be able to individualise the care to her, maybe after due consideration, not taking on the advice of one of the members of the multidisciplinary team. I'm not deriding multidisciplinary care overall. I just think that the more providers you put into any care, the more likely you are to fragment that care, and the more difficult it will be for that woman to feel that her decisions in particular about her journey are really taken into consideration. Yep.
Thanks. Thanks, Chair.
Thank you. Honourable Mark Banasek.
From a lot of witnesses today and obviously throughout the course of this inquiry that they feel dismissed about them as an individual. And picking up on your submission, Dr. Henman, you talked about embracing the imperfection, embracing that individualised care. How do we do that on scale, given that obviously it's a stressed situation in terms of resources? I'm picking up on what you said, Dr. Beck, about it not becoming a ticker box exercise. How do we do that without it becoming a ticker box exercise and actually maintaining that authenticity of actually engaging with that patient as an individual? Is it just purely resources, or is it some practical things?
I think that's a really good question, because that's the practical application of everything that you are listening to. I think it's actually the language that we use. Language is one of our most powerful tools. Our tools are, yes, our medical knowledge and our hospital resources in terms of our physical resources are really important, but language is insanely powerful. The things that women take home with them isn't, I would say that as a general rule, the things that you've heard haven't been about the physical location, or it's been about how they were communicated with. And so I think that the very first thing for me is that the birth and the pregnancy belongs to the woman. The birth and the pregnancy does not belong to New South Wales Health. And so if that's something that could be culturally something that we put out there, because as soon as we do that, it means that we automatically default to consent. We say to them, this is what we think, what do you think? And when it comes, continuity of care is certainly one of the pillars of what we've talked about. But if you, as an organisation, automatically assume that the pregnancy belongs to the woman, and so anything that we do to that pregnancy we have to gain consent for, then I don't think we can still practice within guidelines within that kind of approach to women-centred care. I don't think it's not the guidelines that are the problem, it's the way that we implement the guidelines.
I think part of it will go back to what some definitions we use. So commonly you hear the term normal birth, and people probably automatically assume that means a vaginal birth. Not quite sure we should be saying that, because if a woman feels as though the best birth for her, for example, is an elective caesarean, well then that's her expressing her individual views on how that should occur for her. And so we've addressed the individual nature of humans by asking her about that and asking her what her definition is of the perfect birth. Secondary, I suppose, and go back to a little bit what I alluded to before about guidelines. Say, well, we need to individualise our care and take into consideration the imperfections of humans. Guidelines can't be set up, as you alluded to, can't be set up about individuals. They're set up on groups of people, but groups of people will, some of that group will exist on the edges, so they need to be treated differently. That requires resources and education and everything that Trudy just alluded to that we need to be thinking about in recommendations from today.
Thank you.
Yeah, sure.
In all of this discussion of guidelines, I think we've just been skirting around the edge of discussing the medico-legal environment that you're practicing in, and I think one of you earlier mentioned sort of risk aversion within hospital systems. I was hoping you could comment on the medico-legal environment as it stands and the impact that that's having on practice, and if there would be any useful changes to it.
It has a massive impact on practice. I don't think you can overstate it, to be honest. I have almost no doubt that almost every submission that involved a criticism of one of the healthcare professionals involved, that healthcare professional was worried about what would happen if they didn't do the intervention that they did. So overall, it's maybe outside the terms of reference of this inquiry, but the medical legal system has a lot to answer for here, because I doubt you'll find a doctor full stop, let alone a doctor or a clinician involved in obstetric care that isn't somewhat fearful of what will happen if there isn't a perfect outcome. But of course, there are no perfect outcomes. So it's a perfect storm for medicine and a perfect situation for the medico-legal community. But that being said, and I struggle with this myself every day, I try not to let that, as best I can, influence the care that I provide, even if it is at the edge of guidelines, because many times I think acting at the edge of guidelines, is obviously, I do think it's the best thing to do for that particular woman. And overall, if we genuinely strive to do the best thing that we can possibly do for the woman sitting in front of us, we should, you would think, leave ourselves less open to medico-legal problems. Now, that's not actually the case, but it doesn't mean we shouldn't strive for that. But, yeah, the summary to your question is the medico-legal environment is a minefield, a treacherous one, and unfortunately marching in a direction that is very, very sad.
Did you have any comment?
Oh, I guess we talk about this frequently at work. I think the hospital I work in, there's a healthy culture within the department of I have never felt that there was attempt at blame or finger pointing, or I think that it deals with complications in a really healthy way, because we know that in this process there will be complications for some women. The medico-legal side of things, I guess, is at the back of all of our minds all the time. And I agree with Carl, it's less likely, I guess the healthcare system is risk adverse from that perspective. And so we're inherently encouraged to adhere strongly to guidelines so that there's less, I guess, room for interpretation of clinical decision making. But I agree with Carl that the problem is that the submissions that I've read and the hearings that I have listened to is that that's actually one of the features of the care that women don't like. So, and that's what I alluded to in my opening statement, is I think that it's an inherently challenging area to work out how do we provide individualised, perhaps like Carl says, on the edge of guideline care, but still be able to assure people safe outcomes for both mothers and babies. And I know that there's been allusion to in previous submissions about the idea that the World Health Organization recommends 10 to 15% caesarean section rates. That's just never going to occur in Australia. That is not going to happen, because who is the clinician who's going to sit back and be like, well, we've already hit 10% Caesar rate this month, so I'm going to have to sit on this really average CTG for a bit longer and hope that you're the one that's going to prove me wrong. Like, that's just not going to happen, and nor would, I don't think any clinician would be expected to function under that model. So, like I said, that's one of the things when I've listened to what you're all having to listen to, I just think it's the wicked problem of how do we give the safest care we can give with the best patient outcomes, with the least justly, I guess, allocated medico-legal interventions, because, like, how do you do that?
I think we can address some of the likelihood of ending up, in a medical legal fight by some of the stuff we've mentioned in relation to continuity, particularly after the event. There are a number of cases where it seems that the meat of the case is, I wasn't followed up appropriately, and then of course the woman becomes, increasingly disgruntled about the trauma that she has suffered because there was inadequate follow-up and inadequate debriefing. So I think we can address part of it by aspects of what we're discussing today. There are parts of it we are never going to address, and for that, in that sense, I recognise what you're saying about, well, maybe what you're alluding to. The guidelines are, in part at least, there for a reason, and but they're there for the majority of the middle of the bell curve. They're not designed for the edges of the bell curve. And I did say in my submission, what's right for one woman will be catastrophic for another. That is true both emotionally, mentally, and physically. So, individualise your care.
Thank you both for coming in today, and thank you for all your advocacy in this space as well. We really appreciate it, and we appreciate the evidence that you've given us today. I don't think any questions were taken on notice, but if the committee has further questions, then the committee will be in contact with you about those questions. And we thank you both again for coming in today and spending time with us.
Thanks.
Thank you.
Thank you. The committee will now break for lunch and will return at 1:15. to avoid referring to specific names, hospitals or medical facilities in their evidence, and to speak generally about the issues raised in the terms of reference. Could I ask to begin with for each witness, starting from my left, to state their name, position, title, and swear either an oath or an affirmation?
Thank you. I'm Lucelle Herman. I'm a registered midwife, and I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you.
My name is Rebecca Quiring. I'm also a midwife. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
My name is Andrew Heap. I'm the Senior Manager for Primary Care Engagement at the Murrumbidgee PHN, and I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. And Dr. Beck, you don't need to either swear in either an oath or an affirmation, as you already have done so this morning. I would ask if anybody has a short opening statement that they would like to begin with.
Ours is twofold, beginning with Rebecca.
Okay, wonderful.
Okay.
Fantastic.
Okay, so we work in a standalone level 2 birthing service where midwives are the primary care providers, caring for women throughout pregnancy and for up to 6 weeks postnatally. We provide local care close to home for women of all risk, consulting and referring to higher level services as required. Women with no or low identified risk factors may choose to plan to birth with us or at a higher level facility. Women with identified risk factors plan to give birth at higher level facilities. We provide a 24-hour on-call service where 2 midwives are on call for planned birthing and unexpected presentations. To better explain continuity of midwifery care and its impact on outcomes, we've got some documents to table. So we'd like to table Sandel et al., which is a Cochrane review focusing on outcomes, Tracy et al., focusing on outcomes and cost effectiveness, Foster et al., focusing on women's experiences, TAFE, Cummings and Catling, focusing on the next birth following birth trauma, the Continuity of Care Handbook and the New South Wales Midwifery Toolkit, both focusing on implementing continuity models of care. There are numerous barriers to providing continuity of care and to women accessing their chosen model of care. In early pregnancy, women attend a GP to confirm their pregnancy and refer to a maternity care provider. This immediately undermines a woman's innate ability to trust her body and tells her that the provider knows what's best for her and her baby. This can limit options available to the woman, as the GP may only refer to their preferred provider even when multiple options are available. Many clinicians in the wider community don't understand what continuity of care or the full scope of practice of a midwife is. The ethos of clinicians vary widely, with some believing in the physiological process of birthing only needing intervention in select circumstances, versus seeing pregnancy as a pathological state to be managed, only occurring without risk retrospectively. As the tabled evidence demonstrates, the philosophy of a care provider directly impacts a woman's outcomes and how she feels about her birth. Women have been exposed to traumatic accounts of birth from a young age and carry that with them throughout their journey. There is a perception that intervention is needed, just in case, and trust in the birthing process is often a journey from a high intervention first birth to seeking like-minded care providers and a physiological subsequent birth. Our maternity care system is provider and organisation centric, with rural women expected to travel long distances with great financial expense for appointments that could be done virtually. Our community of more than 10,000 people doesn't even have basic ultrasound facilities available. Fundamentally, a woman's experience is seen as secondary to physical measurable outcomes. Continuity of care is not seen as core business in Australia, but rather as a luxury alternative to fragmented care.
To follow on from Rebecca, I'd like to offer some possible solutions to some of these barriers to women-centred care and midwifery continuity of care. Access to the majority of maternity care options and or Medicare funding for these in Australia is via GP referral, which can be limiting due to lack of knowledge or potential bias. We propose that women and pregnant people should be able to self-refer to a care provider of their choice for their pregnancy, birth and postnatal care. In terms of options available in the public health system, midwifery continuity care should be the primary option, as evidenced by the documents tabled earlier, which demonstrate the improved outcomes offered by this model of care.
In order for this model to best respond to women and pregnant people, the governance surrounding the care needs to be consumer focused. For example, many women have reported risking out of their chosen model of care as a contributing factor to their trauma. This focus on risk assessment often takes priority over the woman's choices and does not consider that risk assessment is subjective in nature. We propose governance that places women and birthing people's autonomy as the highest priority. Improved clinician education around legal liability is also required, as fear of litigation is often cited as a reason to enforce procedures. However, this is not necessarily reflected in current legal practice. An additional barrier to midwifery continuity of care is a procedural reliance on medical oversight for care that is within the midwifery scope of practice. Organisational acknowledgement and governance for midwives as primary care providers, as well as increased support for endorsed midwives within public health will assist with this. When additional consultation or referral is indicated and accepted for medical or allied health services, we suggest rostering practices that support consistency of these practitioners. In rural communities, access to virtual care options will also reduce the financial burden of travelling for consultation as indicated. With regards to funding, the current scheme involves activity-based funding, which incentivises intervention and therefore over-treatment. We suggest bundled funding to reduce this risk. We also suggest a process by which a woman or pregnant person can utilise funding to access care of their own choice. We also suggest this concept is applied to education to offer the opportunity for families to seek education from a broader range of options. Finally, we would both like to offer sincere thanks for this opportunity. We cannot stress enough that the most important voices in the room are the women, pregnant and birthing people, and families, and we hope to amplify their voices. We also humbly acknowledge that our perspectives will not always align with the lived experience of every consumer, and we are here to listen, learn, and respect the choice of every individual.
Thank you. Mr. Heap.
Yes, thank you. And this joint statement is on behalf of myself and Dr. Trudy Beck in relation to the Murrumbidgee Antenatal Shared Care Program, facilitated by Murrumbidgee Primary Health Network, or MPHN for short. We would like to table two documents as part of this statement. The first, a brochure for women who are pregnant to understand their options for antenatal care in the region. Second is the 2023 GP checklist for antenatal shared care. To begin, I'd like to say that general practitioners are well positioned to care for women who are identified as a low-risk pregnancy. Often GPs already care for these women as part of their practice or have been involved in preconception care and advice. Then in the postpartum period, they will continue to care for both mother and baby as part of their regular routines. And when GPs are caring for women in the shared care pathway, they will have at least 7 interactions with a pregnant woman during her pregnancy, alongside 3 interactions with the hospital antenatal clinic. These are at the 14 to 18 weeks period, 28 weeks, and finally at 36 weeks. Postnatal checks under the shared care pathway include 4 mother-baby appointments in the 14 months after birth. And as you can see, caring for low-risk pregnancies in the GP setting provides many benefits, including continuity of care and integration with the hospital to prepare for birth. Our GP Antenatal Shared Care Program Orientation and Update Workshop has been hosted annually since 2011. The pathway option provides choice, continuity of care, and greater accessibility for women by seeing their general practitioner during pregnancy. MPHN has led the development of the program and associated workshops in collaboration with the Wagga Wagga-based hospital and local GP obstetricians, of which Dr. Trudy Beck is one. Across the region, we have 20 GP obstetricians, and while they do not have to attend the workshops, many of them do attend annually. The workshops are designed to provide GPs with the relevant information and training to deliver a high standard of antenatal shared care, which includes referral pathways when low-risk pregnancy deviates from normal. GPs and GP registrars must qualify to be listed as a provider of antenatal shared care services and are listed on our brochure, which is the first table document, and that's updated annually following the workshop to ensure GP listing is accurate. GPs who do not fulfil the eligibility requirements are taken off the listing, and our current brochure, as tabled, includes 69 GPs and GP registrars listed as shared care providers. And in addition to the antenatal shared care program training, MPHN also leads the work on providing localised information through the Murrumbidgee Health Pathways platform. This online platform contains 11 clinical and 5 referral pages, localised, relating to pregnancy, lactation support and maternal postpartum checks. Thank you.
Wonderful, thank you. We'll now move on to free flow questions. So different members of the committee will indicate to ask you questions. I might start with the Honourable Emily Savall if she's ready.
Yeah.
Thank you.
Thanks so much, you all, for appearing today. My first question is to the Leeton midwives. Thanks so much for your opening statements for today. In previous hearings, we've heard that some midwives struggle to fulfil the requirements of the 24/7 on-call roster in terms of that midwifery continuity of care which you provide. How do you propose that we respect midwives' personal caring commitments and their own circumstances that may preclude them from working those on-call requirements as part of the MGP, but also ensure that we provide that sort of enhanced ability for women to access midwifery group practice if that's what they desire?
Would you like to start? Sure, I can start with that one. As a non-parent, I was a caseload midwife, and I chose to leave that position when I had my own child. My colleagues that I was working with all had young children, and the difference between them and myself was support from their families, their partner, their wider community. They all indicated to me that they were more available for their children than they were in standardised care or working the floor and working standard shift work. The flexibility that comes with midwifery group practice means that, yes, you are on call, but your availability is completely different and it is negotiated with the woman. So a woman may prefer to have appointments at 6 o'clock in the evening because that's more convenient for her because she works and that's when her partner's home, and that can be facilitated. And I think the key for any program is flexibility. It can't be a one-size-fits-all approach. And when you're flexible to the needs of the woman and flexible to the needs of the midwife, then we can all succeed.
I'd like to add a couple of things to that. So additional ways to support staffing within midwifery group practices. A lot of job advertisements out there for those positions require 3 minimum years post-grad experience, and that is certainly not necessary within a team that has a culture of support and supporting those earlier career midwives. There is a body of work related to, I think it's called the Wellms study, that looks at midwifery sort of satisfaction and burnout and working in continuity models. And I'd like to take that on notice to be able to provide some of that information as well, if that's okay.
That'd be great, yeah.
And I guess, look, it's probably beyond the scope of our sphere of influence here, but I'd just like to highlight the continued reference to staffing concerns, referring to midwives as a predominantly woman-based profession. It does sort of highlight our broader societal views on womanhood and expectations of parenthood, and there's a whole broader cultural thing going on there where we go, oh, it's women who are midwives, but they have kids to look after, and there's a lot more that as a society we could be doing about that, but I acknowledge that's beyond the scope of what your power of influence would be.
Thank you. Thanks, useful insights. Did you have anything to add, I suppose, before I go into the next questions? No? Okay. Thank you very much to you for providing these table documents to us today. My question to you, Mr. Heap, or indeed Dr. Beck, with regards to the Murrumbidgee GP antenatal shared care program that you've provided us. It mentions the childbirth education classes, which are available, that usually run from 28 weeks and are held, I presume, in Wagga. It references the PCC. In terms of those classes, we heard some earlier evidence today about a video being quite dated. I just wondered whether that was the same education classes. Is there a fee for people to attend? How is the education provided? Anything more you could tell us about those education classes?
So those would be the same classes that are run by Wagga Base Hospital on a regular basis, usually in the third trimester. I think they're continuously working on updating those and trying to keep them clinically relevant. Beyond that, it would be up to the family's choice, and within my private practice, and I'm sure the MGP or midwifery group practice, I would generally encourage people to go beyond that, as that would be the minimum kind of level of education for someone who's wanting to know more about birth, and then look to other private providers that the woman would seek out themselves, like other well-known birth classes that are accessible locally.
Did you have anything to add? No? Okay. Sorry, go for it. Go from your perspective. Yeah, very helpful.
So we did offer classes as part of an MGP and found that they weren't very well received or very well attended by women. COVID kind of gave us a break, a bit of a circuit breaker, and I did some research on women's expectations going into antenatal classes. I also spoke to about 12 women that were seeing us that were attending classes at other facilities and sought their feedback. As a direct result of that, we actually don't run classes at the MGP. We do individualised one-on-one discussions around labour and birth. So our antenatal appointments are a little bit longer than what's considered standard. We do lots of talking about labour, birth and the postnatal experience, and then we have an identified appointment at around about 32 weeks that is longer. Hopefully it's in the woman's home if she'll welcome us into that space, but some women do prefer to come in into our clinic rooms. We encourage their support people to be there, and it's completely individualised to that woman, her expectation, her prior experience and her clinical journey.
To add to that, I guess I just want to highlight some personal concerns of mine. There seems to be a lot of discussion around standardising education and placing programs in place. And firstly, I want to acknowledge that that there are such a broader ways of knowing and seeking information, that Dr. Beck has rightly pointed out that families are seeking information from a broad range of sources, and that does include knowledge that comes from outside of sort of traditional education programs. So, enforcing a standardised education program might interfere with women's options in that respect. Another concern is that standardisation of clinical care has been implemented to the point where the policies are often overriding an individual's choice and autonomy, and we've heard that repeatedly in the submissions that have come from women and families. And so further standardisation does feel concerning to me based on that. And just another idea I want to highlight is that when we're talking about discussing certain interventions ahead of time, and again, I'm here for individualised discussions around what may or may not transpire in the pregnancy, birth and postpartum period, but occasionally it can have the undertones of conditioning women and birthing people to accept these interventions if they're suggested later in time. And it's a very nuanced and balanced thing to do, but it's just a concern that comes up when we keep referring to things like, oh, well, if we talk about forceps births here, that will improve the consent process later. And I'm not denying that education is important, it's just that nuance of it not being in a conditioning space.
Yeah. And my final question, likely to the PHN again, with this document in terms of the 2023 checklist. I noticed that that's the version history there is, it's from the 15th of October. This is quite a recent document. I just invite you to perhaps advise the committee. It's also quite a thorough document. It's very clear. Advise the committee what's gone into this, and particularly anything around the My Birthing Plan form that's highlighted in there.
Yeah, certainly. There is an antenatal shared care committee that meet together, and they're made up of representatives from the Wagga Base, from the MLHD, from the PHN, GP obstetricians and GP shared care doctors. That information is pulled together by that committee through liaising with their various departments, and that's how the document is put together. Trudy might be able to.
Yeah, and I think the important thing is that, again, along the same lines as the Leeton midwives, is that my interpretation of documents like this is a minimum standard in terms of this is ensuring that for the clinician who may not have the breadth of experience that, for instance, a midwife or a GP with frequent interactions with women of childbearing age would have, this is a safety net document that makes sure that those women are identified, any risk factors are identified, and that they're appropriately, they know what their options are in terms of birthing choices. I don't think that this should be looked at as a way to standardise healthcare, because certainly I don't think for any of these documents that's the aim. It's more a safety net for those who are in the GP world maybe infrequently coming across pregnant women.
Yeah, no, thank you. Thanks, Chair.
The Honourable Susan Carter.
Thank you all for being here. I was very interested, Ms. Herman, in your, when you were talking about practical things that we could look at, the idea of virtual care. I wonder if you could explain that a little bit, especially in the context of what we've heard from a lot of women is the importance of them being heard and I think respected by time being spent with them. And I'm just wondering whether virtual care would be an aid or a hindrance in developing that relationship with a woman.
Yeah, absolutely. Thank you for that question. So that suggestion has come from, I guess, experience working rurally, where we don't have any on-site obstetric medical practitioners for women and birthing people to see. So they do have to travel if consultation is sort of indicated and they accept that. And it would be a very individualised approach. So basically just having it available. So for some women, they don't mind travelling the either 45 minutes or hour and a half, depending on where they're going one way. So hour and a half and 3 hours round trip. So some people don't mind that. They have abilities to have their children looked after, they're financially able to take the time off work, and that face-to-face interaction is important to them. Fantastic. Of course, they can go attend the clinic in person, but all of those factors can be really restrictive for families that don't have access to that support. And being able to simply just come into their local midwifery clinic, which is only, say, 10 minutes from their home, and then have, a dialed-in video conference with whatever practitioner is involved, would obviously save them a lot of time and money in that respect.
Yeah, we've actually had women accessing our service that have not attended those appointments because logistically it's just not possible for them, but they're quite happy and able to come and see us. Even taking it a step further, we actually do antenatal care in the home as well for women that can't come in and see us. So I guess from a practical standpoint, if we need to consult with an obstetrician, if we're in the room with a woman, if the obstetrician needs a physical assessment that requires laying hands on a woman, we can do that for them in the room and then communicate that virtually. It's about accessibility. It's about making it woman-centred rather than practitioner-centred and organisation-centred. And I think we have the facilities and the technology available to do it. It's just getting everyone on board.
So if I understand it, the proposal is that it would be used as part of multidisciplinary care. It would be not in the woman's home, but it would be in the group practice. How does that address issues like, I think you said access to ultrasound? Are there issues with access to blood tests or other medical needs?
So we have pathology in our local community. Ultrasound we don't. I did read something somewhere about, was it you telling me about effort?
I've worked at a hospital that was a bit larger than the one that we're currently based at, and they were able to offer a maternal fetal medicine outreach. So they utilised local sonography services, which again won't apply to where we're working because we don't even have those. But they utilised the local sonographer, but then teleconferenced with the MFM specialist in the tertiary centre, who was able to review those images, and they did a consultation with a lead midwife, the MFM specialist, and the woman or pregnant person. So the women were not travelling 8 hours return to get a tertiary level scan. So that's not specific to us, but an example of how it can work to look after women in rural and regional communities.
Very practical question. if we were looking at something that we would roll out across New South Wales or recommend be rolled out across New South Wales, are there communities where I imagine you need pretty good internet for the type of scanning and image reading? I mean, are there just practical difficulties in some communities where we'd be offering something that actually wouldn't work because of internet issues?
My understanding is that the facilities that we have access to have got good internet access, but we can certainly investigate that further and get back to you.
No, look, I'm just raising it as if it's working in Leeton, that's great. I'm aware of other regional and rural communities where there are issues, that's all. And I don't want to set up something that looks good, but build barriers into that is all I'm suggesting.
Yeah.
Thank you.
I've had more discussion of GP shared care models today than any other hearing that this committee has held, and I suspect that's because we're in Wagga Wagga, and that's in part to the work that you've done. So I'm interested in understanding what are some of the attractors or some of the barriers for GPs to sign up as shared care GPs. Do you get that kind of feedback from them?
Thank you. I don't work in a clinical capacity, but my understanding is that this is an area of medicine that's quite complex and quite time-consuming. So there are possibly two reasons why more GPs don't sign up.
Yeah, I think people self-select to this. It's the same as there'll be GPs who don't find their niche in dermatology. There'll be other GPs who don't find their niche in obstetrics. And we have the luxury in our area of being able to easily refer to another practitioner who's more comfortable with that field than we might be ourselves. So probably perhaps the MLHD can talk to more the issues around some of the things that you were referring to earlier, but I think the reason why GP obstetrics does come up in this MLHD is because once you go beyond the kind of hubs of the regional centres, your care is entirely reliant on midwives and nurses working at the top of their scope and GPs who have subspecialty areas. So I think the resources to keep all of the services running in the smaller communities is a constantly evolving challenge. And probably COVID, to a certain extent, in my opinion, has helped us with service provision because it's it's pushed the envelope on what is accepted delivery of care. And I don't know if that's been a shared experience with Leeton, but certainly we've noticed even our access to education has improved in regional areas in the obstetric space purely because of the push for making more things online.
As a follow-up, I'm interested in if you have any sense of the numbers of sort of supply and demand. If someone's preference is to have GP shared care, can they usually get into that kind of model?
I don't think there's an issue in Wagga with that kind of model. Certainly, I know from speaking with my GP obstetric colleagues in the smaller communities, there's high pressures of on-call ratios and frequent issues that then become a challenge for resource provision in Wagga as the referral hub, that when the well-being of the rural midwives and GPOs is critical to the success of the central units, because it might not seem like a lot if a rural hospital goes on what we call COSOPs, where they can't provide safe provision of services. It might not seem like a big deal if it's one hospital having 3 or 4 births a month, let's say, for instance. But if 5 hospitals in our catchment area are doing that, then it puts the central referral hospital under intense pressure. And so it's in all of our, it's to all of our benefit if upskilling and support can occur to peripheral sites to enable them to provide consistent service provision. Because from my perspective, working on the floor at our regional hospital, we're frequently put under intense pressure when peripheral locations are unable to work at the top of their scope of practice.
Thanks.
Thank you. I've got a couple of questions for the Leeton Midwifery Group practice. I'm just wondering how many birthing women you're able to accommodate each year within your own practice, and if you find that there's a demand that's higher than what you're able to actually accommodate?
Yep, so we provide care to about 120 women a year, which has been consistent over the years. Most of those women, however, don't birth with us for various reasons. So these are women that we might be seeing from 14 weeks antenatally. In our community, getting into a GP is becoming more and more of an issue. You're talking about fit, healthy women that don't often become unwell. So if they're not on the books with a known GP, they may not actually even be able to get in earlier than that. So we have been providing consultation to women earlier than that 14-week mark. And then we'll continue to look after them postnatally and then support them as they go and birth in a high-level facility. We do have a number of women that, in terms of risk assessment, could safely give birth with us but choose not to because they would prefer and feel more comfortable to birth in a higher level facility. Currently, we can provide the service that we're doing, but that is only due to the sheer tenacity and dedication of the midwives that work in our practice. Without them, it would not be possible. You can't pick our model up and put it somewhere else unless you also take the dedicated midwives with you. Yeah.
We've also heard a little bit this morning and in other hearings, obviously about staff shortages and particularly shortages of midwives in regional and rural areas. And I was just hoping that you could talk a little bit more about the impact of that and what that means and how that translates to women's experiences giving birth in regional and rural areas.
Well, Trudy actually alluded to that when she used the word COSOPs. So in our facility, if we have unplanned leave or even planned leave that we can't fill the vacancy with an agency midwife, then we have on occasion needed to go on what's called COSOPs, which means that we're downgrading our service, which means that we're not providing an on-call service. So that is definitely an issue. I think it's an issue universally across the world that we are short of midwives. I don't know what the solution is. Who would want to be a midwife at the moment?
And that leads into what I was going to suggest. And look, this is only anecdotal, but in speaking to midwives, there are midwives who are either leaving the profession altogether or leaving the public health system because they can't tolerate working in a culture that does disrespect and abuse women and birthing people. It affects midwives too, and they leave the profession, and I guess it becomes this kind of self-fulfilling thing. And then there's a staffing shortage and the culture deteriorates. Although I also would suggest that being understaffed it's not an excuse for care that undermines, a woman's bodily autonomy and respectful care, even under a lot of staffing pressures.
We'd also heard at one of our other hearings that some women had been able to get their own midwife. However, they couldn't get their midwife the hospital wouldn't allow that midwife to actually be there during the birthing process. Is that something that exists in your experience as well?
Are you talking about a privately practicing midwife?
Yes. Sorry.
Yeah.
Full disclosure, I am planning on leaving the public health system and working as a privately practicing midwife. There is some governance that does allow endorsed midwives to have visiting rights in public health services, and there are certainly midwives who've been able to do that successfully, which obviously is far, far better for the continuity of women and birthing people who either want to or need to birth in a facility rather than at home. However, again, anecdotally, using those pathways to get visiting rights can prove quite difficult depending on what facility you're inquiring at, and it certainly is a big barrier to really enhancing that continuity.
Absolutely, thank you. Honourable Natasha McLaren-Jones.
Thank you very much. I've got a couple of different questions. I might start with the midwifery group. I was interested just to know, you mentioned in your opening statement about being more consumer or client focused, the risk assessment versus choice. How do you find that right balance?
I don't think it's up to us necessarily to find the balance, because a woman's perception of her own risk is the most important thing. So myself as a practitioner or the facility that I work within may say, oh, you know, this is high risk, but that's all in a matter of perception. So what you may consider to be too risky may be different to the next woman. So risk, it's not that we shouldn't be looking at risk, of course we should, but this is all about communication with the woman, and this all comes back to informed consent, which was discussed before, where the autonomy and the decision making is with the woman. No one is more invested in that woman's outcome and the outcome of her baby than that woman herself, and the decision is hers.
Just in relation to the shared GP model, how do you reach the women? Is it purely based from engagement through the hospital or through midwives? How do you, I suppose, to tap into them to say, look, these are the services available?
So essentially women will mostly self-refer because of the breadth of the number of clinicians involved in the program. Most practices will have a GP shared care provider within the practice, in the main practices in the area, and then the practice will triage the women to those particular clinicians, and then my practice would be that I offer the, when I see them at one of those initial appointments, I will offer them the models of care that are available within our area. Unfortunately, midwifery group practice is not one of those. And then they will choose to either have the GP as their primary care provider, or they will choose to go with one of the other models of care.
Are you at capacity at the moment with the number of clients, or what scope do you have?
Do you mean me personally?
Oh, across the whole
across
practice?
the program, I think
how is it managed?
Across the program, I think we would have similar challenges to Leeton. Like, I would say that those are challenges that exist across the entire rural health network. That the difficulties that women will come to us with is that I can't see a shared care provider at this particular practice because that practice's books are closed, which is, I mean, Andrew would probably know how many practices within the region would have their books closed, but it would be the same situation as Leeton. And so, unfortunately, for some women, that does mean that they're left in uncertainty for a period of time while they find a clinician who's capable of pointing them in the right direction, so to speak. But I would say that that's probably a challenge that exists across all the regions, not this one in particular.
Thank you.
No. My question is to the ladies from Leighton, and sorry if you touched on this before, but I don't think you did. Just I'm curious as to, I guess, the genesis or the origin of having that midwifery group practice in Leighton, because obviously it's a smaller regional community. I guess, how long has it been operating? What's been the reason why, and why do you think your community's been able to set that practice up? What led to it for you?
Because of the community.
Yeah,
because of the community. So the Leighton Midwives started in 2016. It started because there was a complete closure of the maternity unit. So they were functioning as a level 3 service under GP obstetric-led care, and it completely closed overnight. The service was completely driven by the dedication of the original 4 midwives working at the Leighton Hospital at that time, the local manager, the MLHD midwifery manager, and the Leighton facility manager. We also had intense community support from the local mayor at that time as well, to establish, I guess, any service. Geographically, we are 45 minutes by car to the next facility that's offering maternity services at 2 o'clock in the morning. That's a very long way. So it's been running successfully since then. I came into the service in 2019. We had, not shortly thereafter, and it wasn't because of me, I hope, we had 75% of the workforce resign. So filling those positions has been a long process, and the service, it's a credit to the midwives working in the service that we've been able to keep it going despite all that. And we're still short one.
How many have you got?
We've got myself and 3 others.
Okay.
Yeah.
Yeah.
And that's providing a 24-hour service 7 days a week with 3 midwives and then myself. It is a big ask.
And that's what you were talking about before in terms of how you manage that as well. So, yeah. Sorry, thank you.
Honourable Mark Benazek, do you have any questions? No, you're good? Okay, wonderful. Well, thank you all for coming here today. Thank you for all the work you're doing as well to advocate for women in this space. There was a couple of questions on notice, I believe. So the committee will be in contact in regards to those. And there may be further questions from the committee as well, which the Secretary will be in contact with you about. And thank you again for your time today and for the information you provided us. Thank you. Good afternoon. I now welcome our next witnesses. If I could begin by reminding everyone this session and to witnesses to avoid referring to specific names, hospitals or medical facilities in their evidence and to speak generally about the issues raised in the terms of reference. Could I begin by asking each witness, starting from my left, to please state their name and position title and swear either an oath or an affirmation.
Thank you, Chair. Jill Ludford, Chief Executive of the Murrumbidgee Local Health District. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Professor.
Yeah, I'm Leonard Bruce. I'm the General Manager at Wagga Wagga Base Hospital and also the Executive Director of Medical Services for Murrumbidgee Local Health District. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Ms. Bailey?
Carla Bailey, Executive Director of Operations for Murrumbidgee Local Health District. And sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Ms. Ford?
Yes, I'm Sandra Ford. I'm the Murrumbidgee Local Health District Midwifery Manager. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be truthful, shall be the truth, the whole truth and nothing but the truth.
Thank you. Does anybody here today have an opening statement they'd like to begin with? Yes?
Chair, I have a statement that I'll make on behalf of all 4 of us. Thank you. Thank you for the opportunity to participate in this hearing and to make an opening statement. Firstly, I'd like to acknowledge the traditional custodians of the land in which we're meeting today, the Wiradjuri people, and I pay my respects to elders past and present and extend that same respect to emerging leaders and also to Aboriginal people here with us today. I acknowledge the courage of the women who have bravely come forward to share their personal stories through this inquiry and the impact birth trauma has had on their lives. I appreciate that there are others who have experienced or witnessed birth trauma who have not engaged in this inquiry, and we also respect your feelings and experiences. Sharing your personal experiences is making a difference by contributing to strengthening maternity services so more women can have a positive birth experience with better communication and engagement throughout their care. On behalf of the Murrumbidgee Local Health District, I sincerely apologise to the women who have accessed our maternity services and found that their needs or expectations were not met. I'm sorry we let you down, and I acknowledge the legacy birth trauma can have on a woman's mental, physical, social and emotional well-being and the impacts on their family. As a Chief Executive, a previously practising midwife, a child and family health nurse and a mother, the experiences you have shared with us have significantly impacted me, and I know many of my colleagues as well. Women have united to have a voice in seeking meaningful change to show maternity services now and into the future can change. We are committed to listening and learning from what each person is telling us to build woman-centred maternity services that support holistic trauma-informed care. In 2022, the Healthcare Complaints Commission informed me of complaints received from the Maternity Consumer Network. I took these complaints very seriously, and at my request, the Clinical Excellence Commission completed a resilience assessment at Wagga Wagga Hospital. The assessment was undertaken by experts in birthing, accountability, and clinical care and safety. The experts found that the maternity service was well prepared for when things go wrong. However, the service could be improved and made 11 recommendations to the district. The district has accepted all the recommendations and is implementing all of these that will strengthen maternity care services to ensure that they are collaborative, equitable and woman-centred. I'm just going to give you a brief update on the recommendations. Enhanced oversight with governance structure at board, district and hospital level. Appointment of a clinical director in obstetrics and gynaecology at Wagga Base Hospital in April 2023. Establishment of a consumer group to co-design a continuity of care model at Wagga Hospital. Further engagement will be progressed with a diverse range of community groups, including Aboriginal and culturally and linguistically diverse women. Follow-up after discharge. A 4 to 6 week midwifery-led postnatal follow-up service has been established to discuss with the woman follow-up and support. Capturing feedback. The hospital has established a consumer feedback survey for antenatal and postnatal care, and results are shared with the consumer group. Mapping the consumer journey in the prenatal clinic. We have recently had a whole group of people come through to map the consumer journey to inform immediate improvement and recommendations that can be considered by the consumer group. Implementation of alternative birthing models and birthing education. The introduction of a new hyperemesis grammidarium model of care for pregnant women to maximise their time at home and at work. Building capacity to care for women who have experienced trauma. Staff from the hospital maternity units have attended a trauma first aid course in November and are active participants in the Mentoring in Midwifery program. And progressing pathways for women who identify childhood or adult trauma in the prenatal period. And finally, environmental improvements, enhancements being made to the parenting room in the postnatal ward. We acknowledge we have a lot of work to do. We recognise that pregnancy and childbirth are momentous events in the lives of women, their families, and that this represents a time of intense vulnerability. The steps we are taking is with the understanding it is not just clinical care we are providing. Our care must encompass respect for the woman's basic human rights, including respect, autonomy, dignity, choices and preferences. These include working collaboratively with women and other providers such as doulas, birth keepers, private providers and clinicians from other jurisdictions. Essential to this is ensuring that woman is placed at the centre of her own care. Our staff across the Murrumbidgee region deliver maternity services in a number of hospitals, community settings and also in the home. Care is provided by a highly skilled multidisciplinary team, including obstetricians, GP obstetricians, midwives, counsellors, allied health professionals and other specialised teams, including mental health, alcohol and other drug clinicians and our Aboriginal health team. Our health service delivers approximately 2,200 babies each year, and our staff are committed to providing safe, high-quality care. We know midwifery continuity of care models are desirable for women and their families, with improved outcomes for mothers and babies, as well as a highly positive experience. Our midwives tell me they have much greater satisfaction working in this way, where they develop ongoing nurturing relationships with the women and their families they care for. The district provides a maternity continuity of model in Leeton, as we have actually just heard. We are committed to creating women-centred models of care for our maternity services, and we are doing this in collaboration with local women, in partnering with the Wagga Birthing and Babies Support Group, representatives from the Maternity Consumer Network. The Wagga Wagga Maternity Consumer Group has been formed to co-design a continuity of care model where women have known carers. There will be no exit point for women should complexities arise during their pregnancy. And there is also a commitment for this group to go beyond co-design of this new model and to continue to play a part in how the services are provided to ensure we improve experience and quality. There is much to learn. The New South Wales Health's key policy, Connecting, Listening and Responding, is a blueprint that has been developed to guide us on our collective journey. We would like to reassure the women who are currently accessing our services that we are entirely committed to providing you, your family and your carers with the highest quality care. I would like to thank and recognise our dedicated and skilled staff, our volunteers and our carers, who all play a vital role in the service we provide to our community. And thank you, Chair. I look forward to answering your questions.
Thank you. I might start with a few questions myself, and then we'll move around the committee. You mentioned Maternity Consumer Network. Has either the hospital or the LHD met with Maternity Consumer Network?
Yes, thank you, Chair. So I have met with the Maternity Consumer Network on a number of occasions, and they kindly provided me with some names of women who had made complaints about our service. I can advise that each of those people have been contacted by the local health district, and really to offer support and also to ask them if they would like to have their concerns investigated by a completely independent expert, obstetrician and midwife from within the New South Wales health system. And those women have appreciated the call. We also invited them if they would like to join our consumer group who's doing the co-design of our continuity of care model. And I'm pleased to say that a number of women said they were interested. Some of them were a bit busy. They're contributing in different ways. Some of them have helped with particular projects. One of them is actually on the co-design group. And we will share with each of those women when we get back the feedback around their individual complaints. And we've also asked for those complaints to be themed, because we think that there's a lot that we can learn broadly across the system from the themes around what we're hearing from people's experiences. And generally, they obviously go beyond safe clinical care. The majority of what we're hearing is all about what we heard from our gracious women today. It's about their experience in the system. It's about us being able to look at them with a deep sense of respect and understand their vulnerability. And those are the themes that came through, along with communication as well.
You mentioned that you offered individual investigations. Did any of the women take up that opportunity? And if so, how far are you along with those individual investigations?
Yeah, so all of the women are pleased for us to have those complaints looked at independently from the health service. And that is well underway now. In fact, we expect to hear something by the end of the year.
Okay.
I'd just like to appreciate that for these women, it's been a long journey. And that in itself is really, really traumatic for them as well as they relive some of the experiences that we've heard today.
You also said that you'd offered these women support. Can you detail what support has been offered to them?
So we offered a range of options for people. So the first thing is if they already had a counsellor who was providing them with support, we offered some payment for that service. And also we offered a range of online supports that we know are evidence-based trauma-informed support.
Is that sort of psychological support? Is it
Psychological support, yeah.
Thank you. It's been mentioned that in response to the complaint, the hospital was going to recruit a clinical director of obstetrics and gynaecology. I'm just wondering if that's occurred, and if so, what changes have been implemented since that person's appointment?
Yes, so that was actually one of the first things that we were able to complete once we received those HCCC investigations. In fact, we did it beforehand. So that occurred in April 2023. We have a new director of our obstetrics and gynaecology service. And I think to Chair, it's about what we've invested in that person, in being a leader. Obviously, as we go through significant change and cultural change within the organisation. So the director is receiving support from the New South Wales clinical lead in obstetrics, and he has been down, Dr. Andy Woods has been down to Wagga Wagga. She's also going to go through some leadership training with the Clinical Excellence Commission in Hetty, and she's receiving some great mentoring as well.
Thank you. I'm just wondering as well what's being done within the changes that have been implemented to ensure that every woman that comes to the hospital to give birth is given the opportunity for informed consent in respect to procedures or interventions throughout birth.
Yes, thank you. And look, we've heard a lot about consent as we've listened to our various people who have put in submissions to this inquiry. Consent is around the conversation that we have with women and how we appropriately allocate time for people to have that conversation with their midwife and obstetrician if they have one. So some of the work that we've done around looking at the mapping of how people go through our clinic to make sure that we can streamline their time and to allocate them with a known carer is really going to help us to allocate that time where we can give people appropriate time for conversations and education. The other thing that we've done is making sure that people are aware of their obligations under the New South Wales Consent Manual. But really, consent needs to be given after informed information has been given. And that's been, I think, the biggest change, where we understand that the woman is the final decider in giving her consent. And it's about asking for her decision in what she wants to see in the options of her care, and also completely understanding that there are processes if she decides that she wants to have a look at another option which is outside of the clinical recommendations. So it has completely changed from giving that decision back to the woman and making sure that the service providers are able to provide enough information for that woman to be able to make some decisions. So it's not about the blunt approach which goes into the hazards and the risks. It's a conversation.
Obviously, that information is so important, and then obviously that leads to that informed consent. And it is one piece. How are you making sure that that's actually taking place, rather like on the ground in the hospital? Like, is there kind of any sort of surveys or questionnaires or anything to make sure that these aren't just discussions, but it's actually sort of being implemented through that whole process?
And Chair, I might ask Sandra Ford to answer that question because as a Chief Executive, I'm that level above the service delivery. So I think Sandra and Len could probably provide further information.
Thank you.
Thanks, Jill. Thanks for the question. So we have implemented antenatal and postnatal surveys for women. A lot of the questioning around that is around respect, whether the women actually felt respected during their care, whether they felt that they had appropriate involvement in their decision-making process, and around those sort of questions to actually get the person's experience as opposed to, what actually happened. So we have had good feedback from that women have felt that they've been treated with dignity, they have felt that they've been respected, and that they have felt that they have had appropriate discussion, involvement, and were the decision makers in their care.
Thank you. Did you find any sort of change through that survey? Like, did it begin one way and then sort of start to shift as those changes were being implemented?
The survey we have had in place probably for around 6 months now, and I think we had probably made some changes prior to introducing the survey. So I don't think there's been a lot of change in the survey responses. We have, it has been 6 months since we implemented, and then we'll go back and review the questions and see what further information we can get out. But it's the woman's experience that we want to get out of the surveys. We've also implemented the 4 to 6 week follow-up phone call with women. That's every woman that birthed within the hospital setting. And we have sort of identified that, as it's probably been mentioned earlier, it's not about the traumatic birth, meaning the woman had an emergency caesarean section, that causes the trauma for women. So the touch point at 4 to 6 weeks is to enable us to have some further conversation with women and to identify if women actually require any further follow-up.
Thank you. And just one final question from me. I understand that you've started implementing a whole range of changes, and I'm just wondering if there's been a mechanism to get feedback from the healthcare professionals that are working in the space, and what feedback they have in regards to changing the way things are done and obviously making quite a large number of changes in quite a short period of time, but whether there's been feedback and what that feedback generally is.
Yes, thank you. And what we've really looked to change is our culture and the way that we see women in terms of their clinical care as well as their whole experience in receiving the care. And we've really done that by trying to embed that culture of deep respect. It's almost a charter, if you like. I think there's been a number of mechanisms through the M&M meeting, which is a morbidity and mortality meeting where staff come together and are talking about the change. I think in that forum they're also looking at the data, and we're very fortunate in New South Wales to have what we call the QIDS MAT IQ, and I don't know if you've heard about that through the hearing, but that's actually every week it's information from our electronic medical record, which is extracted and gives clinicians almost real-time information about some of the things that we're doing in terms of rates of induction, emergency caesarean, and a whole range of factors. And together with the feedback that we're receiving from staff and from the women themselves, coming together and having those conversations is really, really important. But Professor Bruce, you might also want to comment, particularly around the processes for staff to give back.
Yeah, so the M&M processes in the end leads to feedback to the hospital National Standard 1, the Clinical Governance Committee, if there's any particular recommendations. There's also feedback to a quarterly perinatal M&M meeting And they will also provide feedback to the hospital executive and also to the district clinical governance meeting. Clearly, this has been a significant time of change for us as a facility and as a health district. And there's really been significant consultation and collaboration with our staff, regular rounding, regular meeting. And probably the main area where we're currently providing support to the senior obstetricians is in regards to patients who would like to choose a different pathway than what is medically recommended. And we are a little bit exposed in New South Wales that there's no New South Wales policy, which is different to Queensland. There's also no college document. So really a lot of time is spent supporting the clinicians to make sure that they can support women that have a different care pathway and make sure that we look after them and also look after the clinicians. But there's been lots of feedback, regular meetings. The clinical director has got regular feedback with the director of medical services, and in his absence with myself as executive director of medical services. And our feeling is that the clinicians are actually embracing the choice. It's obviously very disappointing for us when the community that we serve don't have a positive experience when we look after them. That's been distressing for all staff, and for us, this is a tremendous opportunity to learn.
Thank you.
Thank you. Thanks, Chair. And I just want to thank you all for attending, not just your session this afternoon, but I did just want to note you've all been here throughout the day. And if I say that, it will be recorded on Hansard, so people will be aware of that who aren't at the hearing, because I know that you and a number of your staff have been here, and I think that's really important in terms of the respect for this process, but also hearing firsthand those stories from this morning. So thank you for your attendance. I just wanted to ask a couple of questions. One, a little bit more broadly in terms of continuity of care, not just here in Wagga, but across the health district. It's something that has come up today, but also in previous committee hearings that we've had, witnesses sort of talking about in whatever model works, but how you can have that sort of trusted relationship. In terms of workforce challenges or pressures more generally, what are some of the ways, I guess, that your health district is supporting, whether it's more midwives or the health professionals that we need? What are some of the positive things you're doing, and maybe what are some of the challenges around that personnel level of support that we need for continuity of care? I know it's a big issue, but anything that you could offer in terms of that would be useful. And
Sandra.
I'm happy for any or all of you to answer. So,
I'll get Sandra to talk about the continuity of care planning. Obviously, something very dear to our hearts with the Leeton midwives who presented today. And as I was chief executive at that time when the last doctor left Leeton, and we were looking at how are we going to continue to provide services for the community. And it was essentially a decision of close and have people travel or do something differently. And we didn't have any midwifery group practices at that time. And so it was the tenacity of the midwives to engage the community and their ability to work flexibly to really set up our first midwifery model. But Sandra might want to talk about, because it's not the same in every community, and we've got a number of midwives who are at different stages of their own family journey around their flexibility to work in that way, as we've heard, I think, throughout this inquiry. But we are particularly committed in the larger centres to create a continuity of care model. And we're doing that with that consumer group, and that's really important that we develop that trust and time, because the model will be different. It will be a model where there is no exit point if complexities arise during the pregnancy, which is very different to other models where people get bumped out of a model and into the traditional model if they have a complexity in their pregnancy. And we're also going to make it available for everybody. And I just want to reiterate, it should be the woman's choice around continuity of care and models of care. Before Sandra answers, and I'm hogging the floor, but I just want to say the GP shared care model can be a really good continuity of care model if everybody is aligned. And we heard today that doesn't always work if there's not good communication. But there are examples where it does work really well, because in some of our towns where we have just a couple of GP obstetricians and a small group of midwives at their local hospital who they get to know, and if they do have to go across to a bigger centre for, I guess, a specialist consultant appointment, they've still got those known carers back in their hometown. And many women might birth in the bigger centre, but will nearly always choose to go back home straight away so they can have their visitors and family and have that whole celebration in their hometown. So it is almost a continuity of care model, and we're fortunate to have that relationship with the Murrumbidgee Primary Health Network, where we have come together collaboratively to make it work, because unless we have that annual review and that conversation about how we need to improve it, it's never going to work. So we're very fortunate. But Sandra, you might want to talk about the work you're doing more generally.
So it was interesting, and we heard from one of the consumers this morning, and I think there's a bit of clarification that we need. We can have continuity of care, which is a philosophy of care, and we did hear from one of the consumers this morning around, the philosophy of care, and she felt that the philosophy of care was the same through whether she was in the antenatal birthing or the postnatal period. Or we can have continuity of carer, which is where you do have a small group of clinicians providing care. So you may have a named midwife who provides the majority of the care, but the women are introduced to the other midwives so that they work in a small team. Because as you know, we're not on duty 24/7. And so we also have to have time away from the work environment. Within our rural sites, we have within our rural birthing sites, we do have GP obstetricians, and the women quite often choose continuity of care with their GP obstetricians. It's their GP obstetricians that follow them through their children's immunisations, their childhood and their illnesses along that way. So we do have continuity of care with GP obstetricians. We also have the smaller numbers of midwives in those rural sites, so that when the women do see the midwives, they do know the midwives. It's a small community. Their children go to school together, they play soccer together. They do have that familiarity with the midwives. In the larger sites, like we've alluded to, a continuity of care model is really important, and it is important to have. I know we've heard a lot about risk and people being risk assessed out of models of care or continuity of care, but in a larger site where you have got a wider and a broader multidisciplinary team, there's really no reason for women to be risk assessed out. Leeton is a little bit different because it is a standalone midwifery unit, so they don't have access to GP obstetricians. It is a matter of transfer to higher level of care when that woman has got identified risks associated. From within a midwifery scope of practice, we actually have the Australian College of Midwives consultation and referral guidelines, and that actually identifies to us as midwives what sort of complexities we need to consult with a medical officer and what sort of complexities we need to actually refer on. So I think there's an opportunity for lots of different models of continuity, but for us, for me, it's about the philosophy. It's about having the woman in the centre. It's about that partnership. It's about that trusting relationship, and it's about that culture through all our maternity services.
Thank you. I'm happy to look.
Susan Carter.
Thank you all for being here. Professor Bruce, if I could ask you perhaps a bit of a technical question, and if you need to take it on notice, I was interested when you were talking about practitioners being open and supporting women who wanted to take alternative pathways and some of the difficulties around that. And I think you flagged the fact that there wasn't a college document and there wasn't a policy document the way there may be in other states. I wondered whether this creates any difficulties with respect to the Civil Liability Act in New South Wales, and whether we need to be looking at, for example, the definition of medical or professional negligence in Section 5.0, where the need to have some peer recognition of this as a pathway, or even issues around the Rogers and Whittaker duty to warn, and whether this creates issues for professionals supporting women wishing to take individual pathways?
This is probably one that I take on notice.
Thank you.
To discuss the details.
Yeah, no, thank you. And Ms. Ludford, if I could ask you, I want to acknowledge that some of the evidence we heard today indicates that the recommendations that have been developed and that are being implemented appears to be making a difference in women's lives. And I also wondered if you could perhaps identify obstacles that the health services met in trying to implement some of those recommendations and ways around it. Especially, I think it's important to the extent that this may be something that informs what happens in other places in New South Wales.
Yes, thank you. And I think there are probably 4 areas where we need to have a look at more system-wide change. The first one I think we've already touched on, which is that informed decision-making, valid consent that you've just touched on, and also ensuring that we do have a guideline to guide clinicians when women choose care outside of the clinical recommendations. I think you can put those things together to say we really need a system-wide approach to how we can do this better for women. The second one is around how we debrief women after birth, because it's not just a matter of having a conversation. So what we talked about, the fact that we are doing post-delivery phone calls with women, but that's not quite the same as a debrief. I think debriefing requires training for the person who's undertaking it, and certainly not determining who is someone who might have had a traumatic birth, because people have had all sorts of previous experience in their lives where they've had trauma that they may not have shared with us, and just the experience of birthing can bring back all sorts of really difficult things to make those people particularly vulnerable. So we can't judge, we can't have an unconscious bias about who or isn't offered a debrief. I believe debriefing should be offered universally to everybody, and that people and midwives can do this, but they will need some specialised training. And the other thing is, in that debrief, if there is information around the system that is important, there probably needs to be a way that we can pick up that as feedback and take it back into all of the things that we're getting in terms of feedback, whether or not that's compliments or complaints or information coming through the data. It needs to be fed back in so that we can continue to make improvements. It's all about making improvements. And if women share their experience and there's issues in there, as we heard with one of our women this morning, but she felt it didn't go anywhere, then women will feel dismissed. So I think part of that debriefing is around offering the immediate support for women, that mental health support, whatever support they need. But the secondly is for us to learn from that debriefing around what the system has done to perhaps contribute to their experience. And the other one is trauma-informed care. And again, I think as a system, we need more education for our midwives and probably our early childhood nurses as well. I heard one of the women today talk about the fact that she received a visit, and we have universal home visiting, as you know, where they receive a visit from the child and family health nurse a week after birth. What a great opportunity for a debrief conversation. It's not just about how the baby's feeding or whether the baby's gaining weight. It also needs to be about the woman, how she is going, how her partner's going, as well as the whole broader family. And there's a real opportunity there to leverage from that, to really be able to broaden that scope of debriefing and trauma-informed care. Yep.
Thank you. Dr. Amanda Conn?
I have a couple of questions, but I first wanted to acknowledge a couple of things from your opening statement, and the first one is your apology on the public record, and I think that is a really important part of healing for the people that have made submissions to this inquiry, so I thank you for that and acknowledge that. And I also wanted to acknowledge the work that is being done to implement those 11 recommendations from the HCCC. It's not ideal that it took a collective complaint to the HCCC for that work to happen, but I acknowledge that that work is underway, and that we heard evidence this morning that that's already having an impact. My first question is about the experience of patients in outlying communities, and we heard from Lytton specifically this afternoon, but obviously Murrumbidgee has a large number of smaller communities as well. Has there been any work done to do outreach to those communities, whether that's with midwives, with an obstetrics registrar, with any kind of virtual care models to try and minimise that travel burden on people that are coming into Wagga Wagga for care that's led by the LHD?
Yeah, thank you. And what a great question, because we have 8 different maternity services across our region, and they all are tiered and networked together. But Sandra has started some really great work on how we might be able to provide that virtual support. So Sandra, I'm going to get you to talk to the work that we've done. And there's more work to do, could I just acknowledge?
We do have one outreach midwife clinic out at Hillston, which is actually Rural Doctors Network funding. I have a midwife out there that provides antenatal and postnatal care 1 day a week for that small community, and that does help women who are birthing in Griffith and, the tyranny of distance, so they can have the majority of their antenatal care with the midwife and then postnatal follow-up with that midwife. We heard earlier today about the woman's experience, which is always really important, and the use of virtual care in that area. What we're looking at and what we're trialling with one of our sites at the moment is to have the woman with the midwife in the site and virtual care into the obstetric specialist at Wagga, so that there is a midwife there providing hands-on care with the woman. So, listening to things like fetal hearts, because it is a little bit difficult to do virtual care. During COVID, we did have some guidance from the ministry around what we could do virtually. But of course, because we do things like psychological screening and domestic violence screening, we never do that screening unless it's face-to-face. So there are reasons why we do face-to-face. But we're trialling to have a maternity care provider or a midwife with the woman, so that then the woman comes into the hospital at her community. And so we're trying to decrease technical issues that might happen, or women not being able to get on to, the internet for their virtual appointment, and then have contact with the specialist obstetrician virtually to try and prevent that process.
For the trial that you've got underway?
We're hoping to commence in January.
And my second question is about the communication with GPs. We heard earlier today that for GP obstetricians who provide intrapartum care in the hospital, they feel very well connected to the hospital providers. But for GPs who either don't provide intrapartum care or aren't GP obstetricians, that they feel like there's a lack of communication or collaboration with the hospital. What work is being undertaken in that space?
I'll get Len to respond to that in a moment, but I guess I just want to start by saying there is considerable risk with the declining numbers of GP obstetricians, as you probably know. And I guess when we're looking to the future, the numbers of GPs are declining at an alarming rate in regional and rural areas. But the number who are choosing to do obstetrics as advanced training is even greater risk. And I think since we've introduced our new Murrumbidgee GP training pathway, where we've employed them as registrars, I think then we've only had one that's actually done and completed his advanced GP training, and he's up in Young and doing fantastic work there. And we really need to think about that, because that is a really big risk to future models, and those continuity models. We need to really understand that, in the next few years, those numbers are going to be so low. We've got quite a few now who are operating on their own. What does that look like in terms of their, their work-life balance? And it's a problem area. I think there's probably more work to do in the communication with non-GP obstetricians, but generalist GPs. In Murrumbidgee, I have appointed a Director of Primary Care who is a GP himself, Dr. Alam Yusuf, And so there's probably some work that we could do with Alarm in his community of practice with his GPs. I think we need to go and ask them what it might look like. And just thinking aloud, Len, is whether or not we have some regular open days where they come in and meet the Director of Obstetrics and Gynecology, get to know some of the consultants, and the midwives equally is important, because there may be times when they need to call a midwife rather than a registrar, I suspect.
So the challenge that we have is the electronic medical record that doesn't allow for non-New South Wales health employees to have access. So that makes it really easy for our GP obstetricians because they access it the same way that I access the medical record. We are currently working with our health information team to actually see if it's possible for us to create access for our Aboriginal Medical Centre medical practitioners as a particularly vulnerable group, because the easiest way to share information is through access to the electronic medical record. Now, that yellow card that's been in place since I was an intern is still there. At least it's some information, but clearly we're very excited about the option of the single digital patient record, where we can see GP records and they can see ours. So it is challenging. It has improved over time. I'm still doing some perioperative medicine. My background's anesthesia, and I spoke to a patient the other day. Just having records scanned in and me not having to go through, 5 paper files to find information is already a tremendous improvement. Clearly, there's lots of anxiety about cybersecurity and providing more access to the hospital network, but we are working with our health information team to see if that's possible, because that would be the easiest way to have up-to-date information. There are some open days, I think at least once a year, between the shared care group where they can get together, and that's also an opportunity to share the newest guidelines and for people to get to know each other. So there are opportunities, but it is tricky. I think the other bit that has helped is having the health pathways that's available for all GPs, and we have a number of services that the MLHD provide that form part of health pathways.
And wouldn't it be great if we had that yellow card, that antenatal card, combined with the birth plan for the woman and available digitally for, there's others, there's doulas and others too that we need to think about, that collaborative approach for the woman.
Thank you. I think that's really interesting information. I have one very cheeky follow-up on behalf of my GP colleagues, which is the open days where they can come in and meet the maternity staff. Are the GPs compensated for their time to attend those?
Well, it's a first question. Definitely something we'd consider, because in the end, it's about looking after patients. And the more engaged they are, the better care our patients will receive.
Probably something we can talk about with the Primary Health Network around a practice incentive payment, something like that. Yep.
And those days also carry CPDs for the GPs. So it is organised by the Primary Health Network. However, it's health, midwives and obstetric team. We provide that education and the clinical scenarios and participate in that day as well. And I do know that they actually can get CPD points for it, for the education.
Thank you. The Honourable Mark Banasiak.
Thank you. I guess my question is to you, Ms Ludford. What you've spoken about a lot today is about cultural change. And we all know cultural change is quite difficult, especially in a large organisation such as a health district. What steps are you taking to actually make sure that cultural change sticks and keeps evolving, given that our midwives, our doctors are obviously in a very busy, high-paced, high-stressful situation, and aren't necessarily always in the front of their mind thinking, this is the new way of doing things. How are you maintaining, I guess, that ever-presence?
Yeah, it's a great governance question, actually, because I know in conversations with our board, who also took this whole experience very, very seriously, is how do we make sure that this doesn't happen again, where we get these voices coming forward that we needed to hear sooner. In terms of cultural change, I think it's about making sure that it's not person dependent. It doesn't matter if I'm not here or Professor Bruce isn't here. The process that sits behind it needs to be entrenched, and it needs to be really clear. And I guess the other thing around culture is we really need to engage with the hearts and minds of the staff so that they own it. But along with that, there needs to be accountability. So we have processes in place. We have a culture change program which has helped in this process called Our People, Our Future. And it is about having aligned goals, aligned behaviours and aligned systems. And so every year we have all have the same aligned goals, and our behaviours help us to deliver those goals, and we have particular coaching mechanisms where we can coach teams through periods of change, because these things are very, very hard to implement, but they're even harder to get them to stick because there's a tendency for people to go back to the status quo. I think in this case, because women sit at the centre of it, and midwives, when I visited the midwives recently at our big hospital, they told me how much they admire the women for coming forward because it's what they want to. So it is about making sure that we align all of our goals and that we own it, but we also need to hold ourselves accountable so that it's a hospital level, then at the district level where we've got a new maternity equality safety governance council that is looking at all of these things, particularly around the consumer feedback and the improvements, and then right up to the board monitoring it through their committee. And one of our board directors is here today who will oversee that process at the board level as well. So I hope that answers your question. It is around governance.
Yep.
Yeah.
It does, thank you.
Move on to the Honourable Emily Savard. I've just got two quick follow-up questions. In regards to the individual investigations, I was just wondering if you knew how many of those were happening.
I'll take it on notice, but I know it's approximately 30. Yes.
And that's being funded by the LHD?
Yes.
Yep.
Yes.
And will those roughly 30 women receive a report, you said, hopefully by the end of this year?
Yes, we should have the recommendations back from those independent experts. We'll ask the women, we will have offered the women how they would like to receive the feedback. So we'll certainly offer them a meeting, but we'll also offer them written information as well. I think that's important.
Thank you. And you talked about some of the support that was provided was a reimbursement of the cost for psychological care or counselling. I'm just wondering, was that a full reimbursement or a percentage of the cost?
I'll take it on notice, Chair. My understanding it was a full reimbursement, but I will check and make sure that is accurate.
Thank you. The Honourable Emily Savard.
Thanks to you all for appearing today. My first question is likely to you, Ms Ludford. You mentioned in your opening statement about the work the Consumer Working Group is doing. I just invite you to advise the committee some more information about the group, how often they meet, what the makeup of the committee is, what they're working on, all that sort of stuff, if you're able to.
Sure. I can, and I'll also go to Sandra because she's a member of that group. But there are 5 consumers currently in the maternity consumer group, and joining them is Sandra, who, as you've heard today, is our midwifery manager for the district, and also Jill Raymond, who's here today, who is our Director of Clinical Governance. And she co-chairs that committee with our consumer representative. It is really important that we offer consumer representatives reimbursement for their time. And so there has recently and welcomed a New South Wales policy to enable us to provide remuneration to consumer representatives when they're doing this really important work with us. Professor Bruce is also a member because I think it's also important that the hospital takes ownership because at the end of the day they're going to need to do the implementation. They were formed in September of this year, and my understanding is they've held 3 meetings. And we have put I guess, the timeframes very much in the hands of the committee because we want to get this right. And the first few meetings, very important that we got to know each other, developed the rapport and the trust. And I think some of the information that's coming back, which Sandra can talk to, those important elements around it being eligible for all women and for there being no exit point if complexities arise, but also them continuing their work after the co-design, the model of care, the continuity model of care is designed, but there's a lot more work to do, as we know, through implementation to make sure that we look to see how it's working, what further improvements we need to make. And I think for me, being able to run through things like a new app or information that comes through and get that consumer feedback as we go through this continuous change process around improvement with the consumers is really fantastic. Just also acknowledging that the Ministry of Health have set up 2 expert groups at a state level, and one of those is the expert consumer group, of which we have invited 2 of our local consumers to join so that they can have that greater conversation around the system change as well as their local change. And the second group that the Ministry of Health has set up is the expert clinical advisory group, which is going to have a look at the continuity of care models, the consent guidelines for women who choose care outside of the recommended clinical pathway, debriefing and trauma-informed care. So I think those are really great topics for the system to have a look at and that we're going to help to feed into. Sandra's a member of that group. She's pretty busy. Sandra, what else is our consumer group doing locally?
Well, our consumer group, also a member, our Director of Obstetrics. So,
Sorry,
the
that was
Director of Obstetrics
a terrible omission.
And the midwifery unit manager from the local site. So there are 5 consumers. We do have co-chairs, as Jill mentioned. The other co-chair is a consumer. So we have been looking at, it has been a process around getting to know each other, getting to trust in the organisation, getting to trust that we are very open to suggestions, and we really want this consumer group to be led by the consumers, not by guidelines or by any other process. We've looked at terms of reference. So, of course, terms of reference was developed in collaboration and in partnership with the consumers, with feedback. We've looked at information brochures. So when we looked at the themes from the complaints or the feedback that had come through, the consumer group, we identified things like pain relief medication, information about induction of labour, which I know came up earlier today, and we have drafted a patient information brochure on that with diagrams, because it can be quite a long process, and I don't think we communicate that very clearly with women when they're going down that pathway. So we've got some brochures out there. The last meeting, we actually, one of the consumers gave a presentation around continuity of care and what continuity of care could look like and what it might look like. And we talked about things like philosophy of continuity of care as opposed to continuity of carer, as opposed to named primary lead carer. And then I gave a presentation around different models of care. So, we can talk about midwifery group practice, we can talk about midwifery antenatal and postnatal continuity of care, and there's lots of different models out there. So we just wanted to explore and provide people with information so that when we do our co-design, it's a model that the consumers think would be a best fit for our communities.
Thank you. My next question is around, and again, it might be best directed to you, Ms. Ludford, in the first instance. You've sort of touched on the work that you're doing with GPs locally, but is there anything else that you can add, I suppose, to describing that work that's occurring locally in recent months, indeed, in terms of helping the local GPs here in Wagga to best support consumers with maternity services?
I might ask Carla Bailey to talk about our sonography service that we've recently established here with one of our GPs in the region.
Thanks, Jill. Just before I talk about that, I might just add with the patient mapping journey through the antenatal clinic that Jill referred to earlier. Part of that process is actually looking at that collaboration with the GPs and how we can strengthen and improve the sharing of information and actually indeed that case management type approach with the GP and the actual service at Wagga, because we've recognised that that is a gap. And something that we definitely can work on. So I think that process will give us some clear ideas about how we might go about that. And we're in the process of establishing some interviews and discussions with local GPs to understand from their frame of reference their experience and how they think we could actually improve that with our service at the hospital. In terms of the fetal ultrasound service, we've heard a lot today about travel and people having to go large distances to access care, and we are part of a tiered maternity network with the Canberra Hospital and their specialist fetal medicine unit. And we have local expertise here in Wagga, and we've established a fetal ultrasound service through that provider that allows women to have scans, ultrasounds here locally, which saves them time and also allows them to go on with their day-to-day business. Many women have more than one child, have other family commitments, and going long distances to access ultrasound services is problematic for these women. So that's something that we've put in place most recently in the last 6 months, and it's working well, and the feedback we're getting from the women is really positive and is encouraging, and I think that's a really great step forward.
Thanks. And my final question is around, well, I've got, many more, but around progressing care pathways for women who identify previous trauma. And that was something that you mentioned, I think, in the opening statements as well. I'd just be curious as to what work is going on there also.
Yes, thank you. And I think we've talked briefly about the importance of doing domestic family violence screening for women early in pregnancy, and then again in the postnatal period, and also the psychological screening as well in terms of prevalence towards anxiety and depression, which is called the Edinburgh Postnatal Depression Scale screening. At least 1 in 10 women experience a level of anxiety or depression either during their pregnancy or after birth. So it's very, very important we identify people early in the process before they start to really get that terrible impact on their lives. We already had the mental health perinatal network established, and that's been well established in our district, and in fact has been part of some research that we're doing. But we've recently realised that we need to broaden that out to be more than just mental health. And so we've recently got a working group going around having a really, I guess, multidisciplinary approach, but not all of the clinicians caring for the woman, but just working out what is a unique plan for that woman. And so that includes social work, and social work came up a lot today because sometimes there are actually things happening in people's lives where social workers are absolutely ideally positioned to be able to assist and haven't necessarily been included in the past. Also for women with culturally and linguistically different backgrounds, also interpreters, and also bringing in counsellor services, particularly around our priority populations area around domestic violence or people who've experienced previous sexual assault. So all those people have come together, but the idea is how can we develop a unique plan for women that is individualised to them? And so they started work. They've had a couple of meetings now to make sure that early in pregnancy, when we do this screening, that something happens with the results and that it is obviously discussed with the woman around what her needs and referrals might look like.
Thank you. Thanks, Chair.
Sure. Would you be able to table the terms of reference of your consumer group either publicly or confidentially to the committee?
Yes, yes, happy to. Thank you.
Wonderful. Well, that brings us to the end of today's inquiry and this session. Thank you for spending time with us and taking time out of your very busy workloads to come and give us evidence today. We appreciate that. And I believe there was some questions taken on notice. So the Secretariat will be in contact with you in regards to those. And the committee may have further questions as well, which they will contact you about. But thank you all again for attending today. I know it's been a difficult one to address, but we really appreciate that you've been able to come here today.
Thank you.